And my heartiest welcome to all of you, all the delegates and also the panel. And this is our 26th live surgical program. I think way it's going and every day, every program, I mean, the viewers keep on adding. And this is the 26th program where we thought that definitely then we'll bring in some very interesting cases as suggested by Dr. Rajiv Pachori. And today we have very interesting cases and led by Dr. Satish Jain and also associated with Dr. Rajiv Pachori, Dr. I. Cherian, Dr. Vinod Felix from Trivandrum. We have moderators today, Dr. Sripati Sandeep Naidu and Dr. Ubo Mittal. And I'm very sure you will have a lot of take-home messages. And once again, on behalf of Sun Pharma, Pharma Care Division, this is Mahendra Verman welcoming you all to this program. And I would
for you to log in.
Yeah, I would request your support for our brands like Montec FX, Cipodum XP, Recipar, and Econia. And I'm very sure our association with this ENT faculty will continue in the coming days. And definitely it will be a very good association and it will be a fruitful discussion for all of us. So once again, my heartiest welcome and let me hand over the session to Mr. Amrish Sahai. Please be ahead. Yes, sir.
Thank you, Mr. Varman, and I'm thankful to all the delegates who are joining us. Of course, this is Sunday morning and it's a Shara day. So thanks to the beautiful families for sparing you today for this wonderful event, which is going to be held under the leadership of Professor Satish Jain and of course with Dr. Rajiv Pachori and Dr. Cherian, Dr. Vinod, Dr. Uda Mittal and Dr. Sandeep Naidu. Blended with the presence of Dr. Bhumkar. So I believe that in the last few months of time, everybody is started coming or has come from the unprecedented times through which we were now passing through. Thanks and salute to all the frontline warriors, very especially to all the doctors and the nursing staff for helping the entire community of not only India but entire world. Gradually the cases of corona are coming down and I'm sure that within a very short span of time we all will be free of this corona disease from our country as well as from the world. Sun Pharma had always been on forefront on all the ENT programs of our country. So we wish that very soon we are together for the not only for virtual meetings but for actual meetings as well. With this, I would like to hand over the session back to Dr. Rajiv Pachori. With this, over to you, Dr. Rajiv, sir.
Good morning, friends. Good morning, all my dear friends from this country, abroad, all around.
Sir, IP Cherian sir has joined, I think.
Yeah, Professor Cherian has joined, I think. So, this is the 26th webinar, surgical webinar, and today I have just realized that we have finished 5 months for conducting this webinar. Today is 26th. We started on 26th of May. So again, big thanks to Sun Pharma, big thanks to all the audience and all the people who have joined us and who have supported us in this matter. And today, I would, from our team, I would like to say sorry to all the people that's because of the day of Dussehra, we are doing this academic activity, but thanks to God that He has given us good cases because we wanted to share good cases with all of you. And we got very good cases because these are very uncommon cases like season CSF and olfactory neuroblastomas, adenocarcinomas, which we could do with the endoscopic approach. So that's why we shared this platform today on the day of Dussehra. So happy Dussehra to all of you, happy Navratri to all of you. And again, big thanks to all for this being with us in the last 5 months. And I'm sure we will go ahead with same activities with much better presentation in the future also. So again, thanks all. And I would like to request Udbhav or Sandeep to say something Then Dr. Ashish Bhumkar was, because he is the pillar with us. He is with us since starting. And Ashish was a few comments, and then we will also turn to Dr. Satish Jain. Thank you.
No. Go ahead. Please introduce Vinod and Dr. Cherian. That Satish is doing.
Thank you,
Yeah,
Ashish.
Satish is doing.
Yeah.
So, good morning, everyone. It's a pleasure to have you all again on this big day. And to add on to our series of skull-based surgery, this is new addition to the endoscopic skull-based surgery. And we are pleased to have guests with us, certain people who are dedicated skull-based surgeons, I would say. And to introduce and welcome Dr. I.P. Cherian. Is a very, very popular neurosurgeon, not only in India, but abroad everywhere. Presently, he is the Director of Neurosciences at the Krishna Institute of Medical Sciences at Karad, Maharashtra. Earlier, he was practicing in Nepal as well, but now he's shifted to Karad. He is highly academically oriented and is recognized in the neurosurgical circuit all over the world. He has been the Counselor General of Asian Congress of Neurological Sciences. I have seen him operating once the cystonostomy for severe or moderate brain injury. He is something who has invented very unique procedures to help those patients with traumatic brain injury, the cystonostomy. And I have witnessed him doing once in Jaipur when he came for the skull-based meeting. He is member of World Federation of Neurosurgical Society, and he is an associate chief editor of Surgical Neurology International, a very, very popular journal. And he's a reviewer of a prestigious World Neurosurgery Journal. Thank you, Dr. Cherian. And presently, he's the chief editor of ACNS Surgical Manual. Thank you for being with us. I've been, blessed to have done certain workshops with him and learned a lot from him. He's amazingly talented person who has described the middle fossa approach in a different way, particularly Dolan's and the subtemporal approaches in his own way. Thank you for being with us. And today I'm sure we'll be benefited by his presence, his comments, his points, whatever he makes. Thank you, Professor I.P. Cherian.
Satish, it's an honor to be with you all. I'm sure I can learn much more.
Pleasure for us and for everyone who is watching today to learn from your experience. Thank you. And then I take this opportunity to invite our own Dr. Vinod Felix. He has been a prominent person in the skull-based circuit. I have seen him operating a couple of times, and he's posting his, amazing work on the endoscopy as well as skull-based surgeries, particularly cavernous sinus. He has a deep interest in the cavernous sinus, surgery, and we have seen him operating a couple of times. He is presently working in Trivandrum with the prestigious ENT and Endoscopy Skull-based Center at the SUT and KIMS Hospital in Trivandrum. Thank you, Dr. Vinod Felix. Thank you so much.
Thank you, sir. Thank you, sir. It's an honor to be here. Thank you, sir.
Comments are most valuable.
Thank you, sir. Thank you.
Ashish and Narayana have been, part of our team always, and we know how beneficial they are to everyone by making their comments, sharing their experience. Thank you, Ashish and Narayan. Thank you again for being with us.
Thank you, Rajiv. I want to, on a very lighter note, sorry, may I comment?
Yes,
on
please.
A very lighter note, I want to comment, and it's more of a joke. When I told Satish that but 25th is a Dasera, he said, Dasera kya hota hai? Because the only religion that he follows is service and work. And actually, the Jain ENT hospital, I give the analogy of the famous Harivansh Rai Bachchan's Madhushala, where he says, Din ko holi, raat Diwali, roj manati Madhushala. It is Dasera for Satish Jain and his hospital and all of us on the daily basis. Satish, thank you.
Thank you, Ashish.
Thanks to your family and Sonakshi and all the kids. Yeah.
Thank you. And big thanks to Sun Pharma, of course.
Of course,
who have been, unconditionally supporting our all academic events. Thank you so much once again. Thanks to Rajiv Pachori boss, Udbhav and Sandeep for
Thank
being
you, sir.
part
Thank
of
you, sir.
this
Thank you, sir. Thank you.
team. Thank you. So, to begin with, today our day is dedicated to endoscopic skull-based surgery. And this science is one, believe me, in the entire medical science, this is the fastest growing science, the endoscopic surgery. And it has changed the management of many skull-based pathologies. Skull-base is a watershed zone between the neurosurgeon and otolaryngologist, and still there are a lot of reservation among both the sides regarding the cases, regarding making the teams. And believe me, it's a time to make the team, because the skull base is a zone where many of the intracranial pathologies going extracranially affects, and many of the extracranial pathology which go intracranially affect the skull base, and it requires a teamwork both from the neurosurgeon and the ENT surgeon side, and it has replaced many of the treatment modalities earlier what traditionally we used to do to address all these pathologies at the skull base by traditional transcranial methods, by traditional open approaches. Now endoscopy, by its brilliant illumination and visualization what it provides, and along with that, the advancement in the surgical technology, advancement in the navigation and the imaging system, advancement in the you know advanced drill systems, camera systems, so many other things, which has given rise to this development of this particular specialty. And like the cases what we have kept today, traditionally would be addressed by the transcranial approach. Olfactory neuroblastoma traditionally has been addressed by a combined approach or a transcranial approach. Similarly, any skull-based pathology like adenocarcinoma we have today going intracranial. CSF leaks particularly, when this skull-based science, endoscopy skull-based science started with addressing these lesions, CSF leaks. So CSF leaks would traditionally be managed by neurosurgeons with the open transcranial approaches, but with the advancement in the endoscopic technology, now it has taken over, and it has been believed by the neurosurgical societies now as a standard approach to address the CSF leaks, the endoscopic one. And I believe Dr. I.P. Cherian would agree with me. Can you hear me, boss? Can you unmute?
Yeah, completely, Satish. I completely believe, and I think it should be a team. And of course, I mean, we can, how much ever we try, we can never come to the surgical excellence that we know you and the otolaryngologists possess. We can never come to that level. We are comfortable inside, and until that, unless we make a team, it's always going to be a little bit of compromise here or there. So it is time that in India we start to make teams, between, I've seen your work. Really incredible work that you're doing. For example, Narayan is doing incredible work. Sampath is doing excellent work. So all these people, along with us, real skull-based neurosurgeons, if they come together, India will be like the Mecca for skull-based surgery, because we have so much of talented people around here who we have no dearth of cadavers. And, it is just a matter of time that if we can come together as a team and understand, for example, many parts that I see in one perspective are completely different from your perspective. So that is what I'm learning all the time. I'm learning from you guys. And I hope I may be able to, put forward a point or two from my perspective.
We would like to know. Anytime, feel free to interrupt me, boss. Anytime.
Yeah, sure. But I must say that today I have a few things like pujas and all that. So I have to, because
I know you told me. You feel free whenever you feel like, going.
I would just take a small break and then come back again.
Anytime. Feel free. Thank you. I remember last time when Dr. I.P. Cherian was in Jaipur for a workshop organized by a neurosurgeon, Dr. K.K. Bansal, where we both demonstrated the middle fossa. He demonstrated from above and I from below with the endoscope, and then we met at the skull base and demonstrated anatomy from both sides. And that was a huge learning experience for me as well.
It was the same for me.
Thank you.
It was the same for me.
So,
thank you.
Coming to the first case of the day, ye connect karna. We are starting our series sequence would be like, we are starting with a revision CSF leak, then for a olfactory neuroblastoma, then a primary CSF leak from the frontal recess, and then adenocarcinoma going to the skull base. So this first case, who presented to a ENT surgeon in February with a traumatic CSF leak, and he happened to repair with the endonasal approach. You know, why we are here, this science is evolving, what mistakes one can commit and how we can avoid that. That is something we are here to discuss with. So he happened to repair this, but after 7 to 10 days, it started leaking again. Then intermittently with the Dimox, and then sometime lumbar drains, and sometime other maneuvers. He kept on postponing the further surgery, and now then the lockdown imposed, and after that he came. So first of all, looking at the CT scan picture, this is the plain CT scan of this particular patient, where what we see, I will show you endoscopically the inside picture. This is what has been done. This is a traumatic CSF leak, See, we are coming from anterior to posterior. Here's a well-developed pneumatized frontal sinuses. Now the frontal is going. See the frontal recess starting, nothing so far. The cribiform plate has started appearing, and see where the defect is in the posterior part of the cribiform. See, unusually it is not at the classically what we see at the level of the fovea. It is little behind, and there you see the through and through gap with some soft tissue shadow being there, as the previous surgeon used some fat or some other grafts. And then as we go behind again, what we see is the posterior ethmoidal skull base, which is intact. What we see here, along with this, some opacity in the top ethmoidal cells in the anterior ethmoidal skull base. So this kind of a defect, which probably what I see, if I see on the sagittal plane, this is not more than a centimeter big if I measure it. If I measure it, it's not more than a centimeter big, probably. Let's see. Yeah, roughly a centimeter, or more, just more than a centimeter, 1.25 centimeter, you can say. In the anterior ethmoidal skull base, it is way behind the frontal sinus, and the posterior ethmoidal skull base is intact. You can see very well on the sagittal plane the kind of defect we are going to deal with. Now, to further assess what has been done earlier, what has been put, and how it is leaking. Since it was leaking, there was no doubt about the repair. Many a times you find a patient with the intermittent leaks, and sometimes patient having no active leak, you don't feel like repairing. But once you have a skull base defect, ideally it should be repaired to prevent meningitis, because even if it is not leaking in the intermittent phase, still it may give meningitis. So the skull base must be reconstructed. And in the intermittent leaks, we have already discussed, our protocol is to get a gadolinium enhanced MR cysternography. But in this situation, it was not required. Since the leak was obvious, the patient came to us with a leak. He said, we had a leak 3 days before, last 2 days not having leak, that kind of a situation. So what we got done further with the MRI, let me tell you 2 sequences of MRI which are very, very important for us to diagnose a CSF leak, to establish a CSF leak diagnosis. These 2 are different sequences for different purposes, what I'm trying to show. The first one, here is the MR cysternography. It is nothing more than a heavily T2-weighted MRI, non-invasive MR cysternography. And what we see here, the prominent CSF, the bright signal of the CSF, and in the dark background, the other things are suppressed, and you can find it more prominent, the CSF signals. And what we see here, see the CSF signals in continuity coming down. This is the level of the skull base on the opposite side, and the CSF signals coming down in the nasal cavity. Can you see this? Is this obvious?
Yes, very well. Yeah.
It is the dynamicity of the MRI which can pick up. Sometimes a still image, like this, is still image may not pick up. A sequence of 3-4 millimeter may not pick up. See, this is something you can pick up on a fine MRI, that is MR cysternography. Can you see very well?
Yes, sir.
Now,
yes.
Sometimes the things are complicated because of the associated sinusitis in that particular region, particularly when the patient is previously operated. So the sinusitis will also give a bright signal like CSF. How to differentiate? The best way to differentiate is the next sequence, that is 3D flare. What you see on 3D flare, just opposite the heavily T2 weighted image, that's opposite the drive image, that's opposite the MR cysternography, the CSF appears dark. Can you see here?
Yes, sir.
And the sinusitis will appear bright. Let me repeat again. On T2 weighted MRI or MR cysternography, the CSF will appear bright as well as sinusitis. Both will appear bright. On contrary, on the 3D flare sequences, what you see here, the CSF will appear dark and the sinusitis will appear as bright as you would see in otherwise in T2 weighted. So how can you differentiate now? Now see the CSF having the dark signal, like here the bright signal, and this sinusitis, what you saw on the CT scan, and what you see on the drive, this bright sequence, this is not CSF. This drive sequence cannot differentiate between the CSF and the sinusitis, but the 3D flare will clearly differentiate, distinguish. This bright is because of sinusitis, and what the dark signal is belonging to CSF. That is how, in difficult situation, one can distinguish between a CSF and a sinusitis by taking into consideration this 3D flare along with the drive sequences. Hope I am very clear about it. I hope everyone is clear.
Yes, sir. Yes, sir. Very clear.
So we should always order. See, the onus is on us. When we are evaluating a case of CSF, like we discussed in our previous webinars as well, this is a straightforward situation with a traumatic one, where the concern of the high intracranial pressure and other things are never. But this is a normotensive situation as far as the intracranial pressure is concerned. Here the concern is to identify the site of leak, to identify the CSF which is actively leaking, and to pick up any associated sinusitis. And for that, the onus is on us to order the relative sequences, that is the 3D drive as well as the 3D flare sequences. Once, if I take into consideration a different situation, that is a spontaneous CSF rhinorrhea, the situation is different, altogether different, because that is most often because of the associated high intracranial pressure. And then you don't need a flare that much important as compared to the 3D drive, which can pick up the signs of intracranial hypertension. And more than that, along with that, you need a MR venogram to rule out any venous sinus stenosis. So according to the situation, we are supposed to order the relevant investigation. That is what something
Satish,
I wanted to
can you comment on the maxillary sinus? Why is there in the flare then it is not seen?
Yes, yeah, it is there.
Okay, that's the cyst. Okay,
it is there.
Okay,
it is there. So wherever sinusitis, it is bright, you know.
Can you tell us the signs for intracranial hypertension? What we have to look for?
Yeah, there are certain signs which we can pick up. We have discussed earlier, like empty sella, where the arachnoid pouch, because of the high pressure, herniates into the sella and replaces the sella most often. That is empty sella. You know, the arachnoid sheath carries along the optic nerve all together to the globe, and that sheath distends because of the CSF, because of the high pressure. And you can see the tortuosity of the optic nerve, distended optic nerve sheath, distended Michel's cave. All CSF spaces become distended. And on next case, which I am going to show, because of the high pressure, has different sites of CSF loculation, new sites of CSF collection into the intracranial space, which prompted us to put a ventriculoperitoneal shunt in that patient, which we are taking up as the next case. So there are different situations. Accordingly, we need to order different investigation, relevant investigation, because if you order an MRI brain, the radiologist may not do the 3D flare, 3D drive, all these sequences. The onus is on us to request all those sequences, because once patient comes back, it is difficult to order again and get the MRI done again. So according to the situation, we need to order MRI. That is the important point I wanted to make. So in this particular patient, we have a leak in the region of the cribriform plate, in the region of the anterior ethmoid. The rest of the cavity is good. Let's see what the previous surgeon has done. And now our goal, since it is a revision situation, our goal is to give us a complete multi-layer repair, and probably I'll be using a local flap as well as to substantiate our repair so it doesn't leak again. So revision situation has to be dealt with differently as compared to the primary, because now you are not supposed to take any chance for the future. There could have been certain regions which led to the revision. So this is altogether a different situation, difficult situation, and we have to deal with accordingly. Any questions before we go ahead, or any suggestions?
So when we can say it is revision, when suppose that we operate one case, we repair the defect, after how much time we can say it is not revision? Like it is not.
Surgery is revision. It is a recurrence or a residual situation, that is different. But surgery is revision. Once you are operating upon the same patient for the same purpose, it is called revision surgery.
Like Dr. Nadia wants to know if we can see a clear defect on HRCT, then do we need to order MRI or we can go ahead with the case?
Yes, in revision situation, you must to rule out any other intracranial pathology which is, given rise to this problem, which prompted us to do a revision, which resulted into a failure. So MRI is always good. Secondly, to rule out any intracranial signs of, high pressure, to see what exactly has been placed, what exactly has been going on, the condition of the adjacent brain, any gliosis or something which has led to, or what material has been used, what kind of reconstruction done by the previous surgeon. So many things we get to know from the MRI.
Yes, sir.
Is the MRI done only in revision or in primary setting also, sir?
It was not done in primary setting.
No, do you do it in all primary settings? I'm asking
now always. MRI is so useful. There is no harm in it. Once you are doing such a big procedure, there is no harm in getting an MRI done to get all information related to it.
Satish, just a quick question. Suppose a surgeon has operated a CSF leak and say taken off the pack on the second day, and then you have a leak. Can you explain the protocol, whether you would go for medical management, conservative treatment, surgical management? This is how long would you wait before you take this patient again? So can you just explain that protocol for a lot of people?
Yes, Narayan, that's very useful, important question you have raised. Now, see, all depends upon the kind of surgical work done by the surgeon, the efficiency, competence of the surgeon, what he has done. If a competent surgeon, experienced surgeon has done and happened to found a leak at the time of pack removal, that is the best time to go back, revise it, and do whatever he can, considering as a fresh situation. That is always better. See, once it is a leak, it has to be repaired rather than relying on the conservative management after the surgery. The situation which warranted surgery and again resulting in the same problem, how can you rely on conservative procedure to deal with that? Yes, but in different situations, sometimes in the high intracranial pressure situations, you may have to need some sort of temporary diversion of the pressure by means of using a lumboperitoneal shunt or something, this lumbar drain for time being, to reduce the intracranial pressure for allowing our seal to take place. So that is a temporary measure sometimes required in situation when there is high intracranial pressure. Or you can do that at the same time when you are operating, finding that you are operating on a high intracranial pressure situation, the pressure is high, whatever seal you have given, if you want to keep in place more secure, you can just, do a lumbar puncture and put a lumbar drainage for few days. That is something required. But yes, if it is leaking at the time of pack removal, it has to be thoroughly revised, because you don't rule out the possibility of meningitis by living like that for what you are operating.
Absolutely.
Any other questions, or do we go ahead?
So we can go ahead.
Okay, boss, before going to the case is ready. I will take this opportunity to invite you all for our next upcoming event, that is supposed to be the biggest otology event of the year, which we are organizing on 21st and 2nd of November. Actually, we were supposed to organize this year's Indian Society of Otology conference, which you all know because of the pandemic, all postponed. So that we converted into a webinar, and this will be a 2 days pure live surgical webinar from 9 to 6, wherein we are going to demonstrate variety of otology and lateral skull base surgeries. And this will be the proposed list of cases which we are going to keep. All these cases are most likely going to be there during the surgical demonstration. And we have the people who are going to demonstrate. We have very, very experienced faculty who are going to demonstrate all these surgeries from Jain Hospital, Jaipur. I'm thankful to all these faculty people. Krishna sir, who is presently the president of Indian Society of Otology, Ravi being the secretary, Movari sir, we all know, Suri Prabhu sir, we all know, is a prominent otologist who devised many, otology procedures. Ashish and Ashim, I don't have to say anything. You have seen them operating, and they are going to show some more procedures. So this is going to be like pure live surgical procedure, which we have converted these 2 days into 8 different live surgical sessions dedicated to these stalwarts who have done phenomenal work in the field of otology throughout their life. These stalwarts, we have, we always owe them to their for their teachings. What we have been doing today is all because of them. So all these sessions are dedicated to these people, all 2 days. And to the most, I would say the best part of the workshop is going to be the list of moderators who are the very, very, I would say, experienced and dedicated otology surgeons across the country and abroad, who are going to moderate various sessions, various surgical sessions these 2 days. So 21st and 2nd of November, 9 to 6 is going to be our course. And I'm so grateful to all these people who have consented to be part of these workshops, and they are going to contribute through their experience. A lot of interaction going to happen, and I'm sure it will be useful to everyone. And because of the blessings from the organizing committee we are holding, and I'm grateful to our teachers, Dr. Bafna sir, Srivastava sir, and A.K. Gupta sir, who have been our teachers, grand teachers who have always guided us. And with their blessings, we are organizing with our, very energetic organizing chairman, Dr. Man Prakash Sharma, and treasurer, Dr. Dev Kumar Pingolia. And the scientific program is designed by none other than these two professors, Dr. Sunil Samdani and Dr. Sunita Agarwal, who is presently the head of department at SMS Medical College, Jaipur. So again, we invite you all on 21st and 2nd of November, 9 to 6, all 2 days for this mega otology event. You all are welcome.
All it's are obviously invited. No registration fees, free
Absolutely
for all, right?
Free. This is going to be a webinar like what we have been doing. Yeah. So you all are invited. Thank you, and let's move on to the live surgical session.
Yes, sir.
So is Aip online?
Hello?
Aip Cherian?
Yes, I'm here.
Yeah, Aip. Hi. Welcome to Karad.
Hey,
Good to see you.
Who's Ashish? Is this
No,
Ashish?
Narayan speaking.
Hey, Narayan. Hey, good to see
welcome
you.
to Karad, I said.
I hope to see you in Karad, Narayan.
Yeah, sure. My backyard. Just a quick question. When you have, say, inner table fractures, okay, what is your ideal method of sealing these fractures? With CSF leads, of course, not settling down.
That is, they say for a guy with a hammer, everything looks like a nail. So I really don't know. I'm not good as you guys are with the ENT technique of sealing these things. So therefore, I always go via mini bifrontal craniotomy, and then I do a 3-layer or a 2-layer repair from above. Now,
Dr. Cherian,
surgeon who's as good as you guys are or as Vinodis, then definitely I will start, and I've seen the results and they're fantastic. So I would convert it. I would not have to do this bifrontal craniotomy anymore. We are now doing, sometimes we do it from a unifrontal mini craniotomy also. We can easily reach up all the way to both sides. But I mean, that's my preferred technique because I don't know. I'm not as good as you guys are with the endoscopic technique, and I don't want to, fail when I do something which is not my strength. That's
Dr.
it.
Cherian, can I ask one question?
Yeah.
You deal with a lot of trauma cases, being neurosurgeon, a
Yes.
lot of patients with trauma having CSF leaks, and
Yes.
you mostly manage them primarily on the conservative line. And many a times I've seen neurosurgeon putting lumbar drain for time being to
Yeah.
manage it conservatively, and many of those patients do well. The
Yeah.
leak spontaneously closes. How do you take a call to take the patient on the conservative line or for a repair in post-traumatic situations?
Yeah. So, we all know that about 80% of the CSF leaks, especially CSF rhinorias, they settle by themselves.
Traumatic.
Uh, the traumatic ones, they settle by themselves. Some people wait a longer time. Some people don't wait for a longer time. But at the end of the day, with a meningitis, they settle. Sometimes they start again long time later. So I would agree with your opinion that if there is a skull base defect seen on the recon CT, and if there is a soft tissue defect as well, it's always better to go ahead and do a repair. Now, there are a few things that you have to consider. One is a raised ICP. For example, all trauma produces subarachnoid hemorrhage, and this can be the reason for either an obstructive or a non-obstructive hydrocephalus. And if this trauma produces subarachnoid hemorrhage, and this can be the reason for either an obstructive or a non-obstructive hydrocephalus. And if this is the scenario, the rate of spontaneous healing will definitely come down, and all you need would be a shunt and a repair. But if you don't do a shunt, sometimes these defects can be very, very frustrating. So we have to look at both the things. But, so that's important. That's very important. Why you should look at this scan and Satish was saying, see whether there's any raised intracranial pressure. You can do ophthalmic evaluation to see whether there's any papilledema or late implications of papilledema like primary electrical atrophy and stuff. So if I take a call when there is a skull base defect, and after the first line of management for about 15 days or so, if the leak is not abating, I definitely go in. I would not be very conservative on that. Is not abating, I definitely go in. I would not be very conservative on that. I would not want to be, because this is something that can kill the patient, and this is something that I can cure without much of an issue.
Thank you. So, are you getting the endoscopic picture?
Yes.
Yes, sir. Very clear.
Hope the picture is good.
Yes, sir. Yes.
Okay. So this is on this side being a revision case. You can't see all the landmarks are, the revision is always a challenge as the landmarks are distorted. And what I can see here, if I do a close observation, close call, you can see the CSF coming out from here. That is most likely, see where the CSF is coming out. And see, there is no landmark at the level of the skull base. So in revisions, our challenge number one, to identify the landmarks. As usual, like in other revision situations. So the biggest landmark we have here is the maxillary middle meatal enterostomy. See, this is one of the biggest landmarks to find out the other landmarks. Once we have seen the middle meatal enterostomy, above that is the orbit. That is the orbital surface. And we have seen on the CT scan, the frontal sinus was good. The frontal recess was good. This skull base is, this area is distorted because of the material the previous surgeon is used, What I'm trying to figure out is the other landmarks, whatever possible landmarks I can. This was the area which we saw. Can you see some secretions?
Yes, sir. Sir, the sinusitis.
Yes, which we saw on the scan.
Yes.
For the trap secretions, which we saw both on the flare and the drive sequences.
Yes, sir.
That is the level of the lamina pepraceae. This is lamina pepraceae, that is the recess, the ethmoidal cell. And if I go with the 70-degree up, I can see the frontal recess. Now, in CSF leak repairs, the biggest cause of failure is the lack of adequate exposure. Once you are doing endoscopic, you are supposed to expose not only the site of leak, but the surrounding area of at least a centimeter all around. And make the area flat by means of removal of the bone or any bone pieces or any prominences, anything coming in the way, to flatten it completely at least a centimeter around the defect so that it can adapt to your graft easily. That is something which is most important. See, that is the frontal sinus. That is the supraorbital cell. Can you see that clearly?
Yes, yes, sir. Yes.
And this is the region of the skull base. See that? This is some seal which was placed by the previous surgeon, which is matured. This is matured into a thick scar. See, this was the remnant of the turbinate.
Yes, sir.
So now what my goal is to expose the area all around by at least a centimeter or so. Not only I will expose, I will flatten the area. I will look for the bony defect, and then I will seal it and then substantiate with something like flap or something, as this is being a revision scenario. So this was to show with the 70-degree. Okay. Now coming back with the 0-degree again. This is maxillary sinus, which is, we have nothing to do with that. So our landmarks are very clear. The maxillary sinus, frontal sinus, the remnant of the turbinate it was which we removed, and one of the ethmoidal cell, that is the supraorbital ethmoidal cell going a little above the orbit there.
Yes, sir.
Now coming to the 0.
Sir, any experience with the fluorescein dye?
Fluorescein is a useful technique to, facilitate the CSF leak, the identification of the CSF leak. You inject the fluorescein intrathecal. I've seen in Singapore with Professor Sethi, but this is banned for the intrathecal use in our country.
Okay.
The fluorescein is an amazing thing, but it has to be used very, very judiciously, very, very slowly over the period of 1 to 2 hours, extremely diluted, because it can lead to intracranial complications. Complications like even transverse myelitis have been reported. Seizures.
What about topical, Satish?
Pardon?
What about topical application there?
Yes, topical you can use. Topical, like our ophthalmic friends using this, you can use it. And once you apply the topical fluorescein, as it comes in contact with the CSF, it turns yellowish green. It's a brown solution which turns yellowish green. So it's useful. Sometimes after repairing, you want to see your seal it can be useful. Now, all this scar, see this? What I intend to see here is the skull base from behind. Yes, straight. इसे city चलाना वापस.
Sir, can navigation be helpful in these cases?
Yes, it is. Navigation is always helpful in the sense it improves your orientation, anatomical orientation. So, like, if you find difficulty, navigation can certainly help. No doubt about it. See now, that is your sphenoid sinus.
Sphenoid sinus.
With so much of scarring.
Yes, sir.
See, what scarring we are facing as a problem is actually the need when you repair a CSF leak. What you want is a scarring. You want a good scar to seal the CSF. But here now, once you operate on a revision situation, the scar becomes a big problem. Now, what I mean to see here is the bony defect. You know, there's a lot of soft tissue which has been, pushed here. Here this. So we have to, when you deal with the revision situation, there are certain principles. We are not supposed to seal the mucosal defect section. We are supposed to seal the bony defect. We are supposed to identify the bony margins and then seal them. Give me the Carrison, smaller one. So what I am, concerned here is identification of the landmark. छोटा वाला दे. अभी जो दिखाया जो हाँ.
You're opening the sphenoid to identify the skull base, sir?
Yeah, widening.
Yes, sir.
Because once you open the sphenoid, open it widely, as there was a lot of scar at the opening, it was closed practically. So now in future, once you deal with, such issues, you have to be thinking of the future as well, preventing the possible sinusitis, secondary sinusitis, if you happen to block the drainage of the major sinuses.
Mucosal.
Yeah, so you have to be thinking that aspect as well from the beginning. The brother. Coagulator is an amazing tool in the sense it coagulates at the same time. It can cut. That avoids the bleeding as well. And that can certainly, help you localizing your anatomy better. See, all this is the previous scar tissue, which I'm trying to see through this thick mature scar. Still it is leaking. It looks so thick and mature. I would not say the previous surgeon has not done a good job. He has definitely done a good job. That is the site of defect. That is, no, coagulator though. So my goal now, my man of the match is the coagulator, Coagulator will give me the opportunity, give me the, help to localize the bony defect. See how it is done. I will coagulate the soft tissue first and then ablate. I will coagulate
Dr. Satish, good morning.
Good morning, sir.
Good morning, Prakash sir. Good morning.
Good morning, Uddhav. Basically, I just wanted to have a comment from your side. Once you are doing a primary surgery for the CSF leak, what are the steps one should not forget to land up in a recurrence? One is the intracranial.
The most important
very clearly that we have to take in care about the surgical aspect. Exposure. You said number one, exposure. Follow the bony defect. That is most
Yes.
important.
Yes. The exposure of the bony margins
Yeah.
are most important. Exposure is the most important part. Sometimes what happens, you happen to find the defect and you try to seal it like sealing a puncture. It may not
Yeah.
work.
Yes.
It may not work.
So if there is a good exposure with the bony exposure, probably our repair is never a problem, that you plug in and it comes out. That may be only possible if you have not delineated the bony defect, isn't it?
Yes.
Because repair, whatever you do, it usually holds. Is that statement correct?
Yes, yes, absolutely.
Thank you, sir. Please go ahead.
So here now see what I'm trying to do. And more than that, not only exposure.
Yeah.
Exposure of the defect and exposure of the surrounding to take up your seal. Like when you repair with a fat or anything, you substantiate, you reinforce with the fascia graft.
Yeah.
And in order for the fascia to stick to the defect, can you see the margin of the bony defect?
Yes, yeah. Very clear.
See, this is most important. Never ever try to see the mucosal defect, right? Never ever try to seal the mucosal defect.
Yes.
Always try to find the bony defect.
Yeah.
And see what a tool coagulator is.
Definitely.
It coagulates, it ablates, it cuts, and then it allows you to see the bony margins completely. I would like to localize the bony margin all around.
Yeah.
See the bony margins?
Yes, sir.
Yes, yes.
Yes.
This is something most important. Without looking at the bony margin, if you are trying to seal, it may not work.
Yes.
That is the bottom line.
And even if it is a very small defect, a small bony defect, then also you should clear the surroundings so that whatever graft we put, the repair we do, that should hold properly.
Yes, it will stick to.
Yes.
It will stick to. Now I'm changing to 70 degree. See, now the picture has changed. We can see the bony defect nicely, what we saw on the CT scan. Can you see now?
Yes. Yes.
Yes, sir. Very beautiful. Wonderful. So we can see the whole defect in one view.
Is Ashish there?
Yeah, Satish, I'm there.
Ashish, remember your case in Thane?
Yeah.
Which had a clival defect with a mucosal tube.
Yes, correct.
See this, the bony margins all around. See, this was a traumatic.
We had measured it at 1.25 centimeters. That's what.
Yeah.
So Satish, can you also tell us how would you manage anterior ethmoidal artery in the vicinity of this area?
Yeah, you can coagulate, boss. No problem.
Say it aloud, not for me, for everyone else.
Yeah. See, many of the times, the artery helps you to, seal your defect. Whatever seal you put, you can keep the seal in place by means of the overhanging artery. Many a times. See now, very clearly visible bony defect from all around.
Yeah.
And this, coagulation with the coagulator itself seals any minor arachnoid leak. See what I'm making? I'm making the intracranial space underneath the bone.
Sir, are you considering a Haddad flap here?
Yeah, I will use a mini Haddad, I would say, not a classical one. But since it is a revision situation, I will show this, how to use it. And it's really useful.
The point Prakash was trying to make was, you should not be scared of the dura. What happens is people tend to stick their surgical thing to the mucosa and not go to the bony margins because they are afraid that they may further tear the dura and increase the size of the CSF leak.
Yeah.
But there's no, you cannot shy away. You have to address because that is what needs to be addressed. And plugging is a very important.
What happens sometimes you feel that the defect is small and we may increase the defect.
Correct.
So
Correct. That is where you tend to sort of shy away from the surgical steps.
Yeah.
And that is the first step of inviting a failure.
Yeah.
So always look at the bony margins. Now see, the repair is a child's game. Believe me, it's a child's play. Once your exposure is good, laga na, sir. Laga. Now I will show all these, sharp bony margins because of the fracture. I want to smoothen them.
Yeah.
See this irregular bony margins?
Yes, sir. Sir, Dr. Fazali from Peshawar, Pakistan wants to know what are the indications for open approach in CSF leak repair.
Yeah, open approach is indicated nowadays. The indications have minimized. Less and less indications are there for open approach. But yes, in patient with a huge skull-based defect, with no vascularized flap available, multiple revisions with high intracranial pressure, still you can manage with a pericranial flap endoscopically. That's why I said, like in our practice, every year we do more than 100 CSF leaks. Rarely needing an open approach, believe me. Rarely. We have done couple of, endoscopic pericranial flap where no Hadad flap is available, no other flap is available. Still you can use the pericranial flap. So with the endoscopy now, with the advancement, there is hardly any need of open approach. But yes, in the centers where the facility is not available, experience is not, neurosurgical facilities there, you can think of in complex situation.
Yes, sir.
See, I
think Dr. Satish, most of the neurosurgeons also now are adopting this. Say 10 years back, they never used to do it endoscopically. I would like to comment from neurosurgeon.
Yes, sir. Dr. IP Jain, sir, can hear his views.
I agree to that part. We were not doing it before because we thought we were not aware of the technique as well as we didn't have the expertise. So now, after getting into endoscopic skull-based surgery, I think this is an elegant way of avoiding a quite large flap. But at my stage, if there is a complex leak, I would still go ahead and do an open approach. But once I am expert enough in endoscopic skull-based surgery to manage it in this way, maybe I'll adopt to the endoscopic. Always we like to go ahead with more minimally invasive approaches rather
now what
than...
I'm doing. Yes, agreed, boss. Agreed for the honest. I'm so happy to have honest opinion from a neurosurgeon. But this is, it's so important. See, what I'm doing now is making the surrounding at least a centimeter around raw areas.
Yeah.
At least a centimeter. Now, whatever I'm doing, considering as a last chance to me from the patient side. See, such a big trauma when you are operating on a patient with a CSF leak and it fails and patient comes back with the same problem, losing entire faith in the doctor. So this is something important because the leak, why we are repairing? To prevent the possibility of meningitis. Many a times, these unrecognized leaks leads to meningitis. Then they are diagnosed in the neurological units and then they are operated for that, the CSF leak repair. So it is important for us to understand this problem. Reverse, I'm making the surrounding raw all around. See, my area is so clear, so under vision. I will see the leak would be sealed either first by my cobblator, the cauterization, and second by the fat. Rest is all reinforcement. The flaps and all that, the fascia flaps and all are not for sealing. They are just reinforcement.
After doing such a good exposure, we don't see any frank CSF coming out.
Yeah,
So, is there any guidance for the all to understand?
Pardon?
Yeah. The frank CSF leak we don't see right now, even after doing such a big exposure.
Yeah, it is sealed because of the cobblator.
Cobblator, yes.
Yes.
Yeah.
Like you seal with the bipolar. You seal the meninges.
Yeah, yeah.
And it stops. See all around
Yeah.
what I've been doing. All around making the surface raw to accept my flap, my graft, whatever I use.
Satish,
yes, please.
Could you just emphasize what you're doing around the frontal sinus opening?
Frontal sinus, the opening
Yeah,
is...
just specify what precautions you will take in that area. And
See, number one, this is very important, Ashish. We always mention that once you are doing such CSF leak repair, you have to be careful, like I said for the sphenoid, to prevent the secondary sinusitis because of the blockage of the drainage of the dependent sinuses. That is what the frontal sinus concern is here. During this maneuver, when you use a lot of tissues around here, around the frontal recess, around the frontal sinus ostium there, you are not supposed to block it. So what we do, I will show you in the end. I will not block this, first of all, under vision, and secondly, for time being, I will be using a stent for the frontal sinus because this opening this looks narrow.
Yeah.
A simple stent that will be your, the intravenous, this set drip sets tube for a few days until we remove the pack. That just to ensure that we don't lead to secondary frontal sinusitis. You see the surrounding? It's all raw?
Yes, sir.
Yes, yes.
This is all good. The sphenoid I have opened, I have widened. The frontal is here, sphenoid is here, and the maxillary is here. The area of the, defect has been exposed.
Yes.
The area surrounding has been exposed. It is ready to take or seal.
Yes.
Now, the next point is 0 degree or reconstruction material. We have already harvested fat, which we have soaked in rifampicin. I will show you. I'm coming back with a 0 degree. At this time, like you asked about a flap.
Yes, Satish, please describe the perfect way of tailoring this flap.
Yeah. So this is not, what I'm going to use is not going to be...
Yeah, the classic. Sure.
This is not going to be a classical Haddad one. I will show you. So according to the length, desired length, you have to develop your flap. Length and the breadth desired. And once you plan this flap, you are not supposed to damage the pedicle of the flap, which is below the sphenoid ostium. See that?
Yeah.
That region should be completely spared from your instrumentation, your cautery, whatever you use in this region. See this? This is the area where my flap is going to ascend, which I am cauterizing. No mucosa should be left underneath. Either you remove the mucosa thoroughly around or you coagulate, devitalize. It is same. Because once you are using flap, if you leave the mucosa underneath, can lead to mucocele and it's a disaster. So either remove it or coagulate it, devitalize it. Completely all around. See this. Give me the drill. See, my area is ready to accept my seal now. Our next case is induced. That is a olfactory neuroblastoma. See, this is a traumatic one. So this kind of situation is expected. This is expected. Bony irregularities, bony, dehiscences. Okay, fine. See, that is the brain tissue. Can you see? Hello?
Yes, yes.
And that was the mucosal tube. Cobblator is very safe to be used on the brain tissue. Be careful while working on these fine vessels. Ensure that this blood doesn't transgress inside the intracranial space. And that is the beauty of the cobblator, you can see. Can you see again?
Yes,
Hello?
yes. Yeah, Dr. Satish, go ahead.
You need a fine, probably a bipolar will work.
Yeah. No, bipolar. I'll just use a Surgicel do mere ko.
Surgicel or bipolar, both are I think.
Actually, cobblator only problem, you cannot see the tip of bleeding from where it is.
No. If it is used properly, it's not going to be any problem. This is, I would say, the best thing. There is a section along with that, with the irrigation.
No, I watch your webinars over 2 months now. I think the cobblator which is used the best way is in the skull-based cases. I mean, the companies, they promote more for sleep apnea, tonsil, adenoid, but probably this is one place where it has the maximum use.
Yes.
Because tonsil adenoids can be done in the conventional way as well, with equally good results. But here, it has got a special role.
So our area is clear, sir. Absolutely agreed to, sir. You, sir.
Yeah.
Now, what Ashish asked about the flap.
Yeah.
So flap number 1, you have to respect the pedicle, not to go in that region and damage it. Number 2, design your flap of the proper length. See here, we have to go all the way anteriorly. We need a little longer flap. It should not fall short. पीछे का चाहिए मेरे को उसको.
Could we make out in the previous surgery what flap was used?
No
Not
flap.
really. I don't see, sir. I don't see.
Yeah, because the hadad, it doesn't seem to be. That looks so healthy.
Yeah.
Probably hadad was not taken
Probably
place,
not
isn't
used,
it?
Not used. Yes, sir. Not used.
Yeah.
And it is not mentioned in the operating notes as well.
Yeah, that's a big problem. Operating note, even the good hospitals don't mention all the details. That is the problem.
We can see thigh mark. I think they must have taken the facial art also.
But why would somebody use the flap? See now, my inferior incision, my pedicle is here. Few millimeters below the sphenoid sinus ostium. I'll stay more below, just above the coina.
Okay.
See one more vessel there. Coming inferiorly towards the floor. towards the floor. I don't need a very, very, wide flap in this case. In the next case, it's a big challenge whether I'll be able to get a adequate Haddad or not in the olfactory neuroblastoma, because there the upper part of the septum is affected. Here, I don't need a very broad flap, so I'm not concerned much. I'm not going very high up. You can see.
Yeah.
See this upper incision? And second is the length. See the length. It should be adequate. If you need the excess length sometime, you can go right up to the vestibule. You can take even the vestibular skin. But here it is not needed. So, see this? I am not going too high up. I don't need a very, very wide flap, number one. I'm not going too anteriorly to the level of the vestibule, as I don't need to raise that big flap. Can you see?
So generally the inferior is defined. That's the standard. And then depending upon how wide you want, you take the superior cut.
Yeah, both ways. If you want a bigger one, wider than the regular one, along with the
include the floor. Yeah.
Yeah, you can include the floor along with the regular Haddad.
Yeah.
Yes.
So for ENT surgeons, it's a very simple flap because we are used to elevating this flap, this mucoperichondrium in our septoplasties.
Yes.
See, I didn't inject anything.
Yeah.
No, patla. Patla. Just keep raising like you raise for the septoplasty,
Yeah.
Scissors. Patla. See what a vascular flap it is.
Yes.
This will give us a, sense of security using this flap, that the area will heal primarily. You know what happens many times when you don't use the flap? You use the free tissues there. The fat, fascia and everything may get necrosed sometime, may invite infection. Which area? At the site of skull base defect. If the infection happens to occur at that site, the chances of meningitis are likely to be more.
Yeah.
This, once it is applied, the area will heal primarily like anything. In few weeks, you will not be able to appreciate anything done in that region.
Satish Jain, sir, there's a question from Professor Bini Faisal of Amrita Institute. She asked, what is the coabulator setting on skull base?
Yeah, I generally keep the coabulator at the high setting 9 and 5. But yes, for the CSF leak, you are, you don't need such a high setting. For tumors, obviously, is a different scenario. But for CSF, you actually don't need. So accordingly, you can reduce. But what I did was 9 and 5.
Okay.
See? Vascularized flap.
Yeah.
This is something wonderful what Haddad and Basa guests has given this endoscopic world.
I remember, Satish, I think you were complimented by Professor Haddad himself, no? For the way you do the flap.
So blessed.
Yeah.
Well, so blessed. See, our flap is going so easily there.
Yes, beautiful.
Can you see?
Yeah, yeah.
Still, I can release a little bit more if I want. See that?
And
So
yet you're keeping the sphenoid ostium open. You're not
yes,
allowing
yes,
the
I
flap
will.
to go.
Yeah, yeah. स्टाफ को ले जाए इंस्ट्रूमेंट भी see the adequate length and the adequate width of the flap is the need. In case you need more length, you can elevate it further.
Yeah, mobilize it. Yeah.
You know, now the surgical science has developed so well with the understanding of the anatomy. This flap cannot be used on the side, generally what we believe, where we have, you know, coagulated the sphenopalatine artery because it is based on the sphenopalatine.
Correct.
What you can do, you
Other
raise,
side,
you raise
opposite
this
side.
flap, you raise this flap on the pedicle of that vessel, first beyond the level of the the pterygopalatine fossa. Beyond the level of the pterygopalatine fossa first, and then elevate this vessel from there and then do your transpterygoid walk without disturbing the vessel.
Oh, okay.
And still you can use on the same side.
Oh, that's great.
Otherwise, you have to take from the opposite side, you know.
Yeah.
I have given some more length to it. So this looks adequate. This is just measuring. I'm not using it right now, but I'm just measuring. See, this is?
Yes, very nice.
The kind of healing this is going to give now. That's why I needed the raw areas everywhere.
Yeah.
Have you know? Everywhere raw areas. My concern are the sphenoid sinus. You can see there.
Yeah.
The brighter straight. See there, and the frontal sinus above. So now, my last part is sealing the defect, which is the simplest part now after this kind of exposure and this kind of flap, 70.
Yeah.
So I'll be using the 70 now. दूसरा मंगा ऊपर से. See this with the 70 degree. I'm taking my flap down. See the situation?
Yeah.
Give me the marrow cell. Take the marrow cell to mop everywhere to see any CSF leak there with the close up. See why this all additional exercise. This is a revision situation. See now? Absolutely clear.
Absolutely clear.
So now the repair is the child's play. What I said. Give me the fat, chota. So surgical fat. See the upper part of the dura is intact.
So one of the delegates wants to know what's the size. Can you measure the size of the defect now and confirm the CT finding? So
yeah, it is very obvious. You can see I measured on the CT scan that it is in the anterethmoidal roof, little behind the frontal sinus, and not involving the posterior ethmoid and the sphenoid. You can see very well. So the size is obvious. Measuring into millimeters is not going to change anything.
Any role of resected middle terminate in primary case? We can use that middle terminate. Any role of resected middle terminate? Suppose can we use the middle terminate mucosa or the?
Yes. So what happens in the smaller defects? You know, smaller defects rather than I told you. The first and the most important thing which seals the leak is the fat.
Yeah.
For reinforcement, you use the fascia, you can use the mucosal graft as well. And in the mucosal grafts, you can take the mucosal graft from the middle turbinate, which you resect. You can take the mucosal graft from the floor of the nose. See what I'm doing? I'm reinforcing my fat with the help of Surgicel. This holds very well.
What is the instrument you're using, sir?
Pardon?
What is the instrument you're using now? Is it a blunt hook?
Yeah, that's a hockey stick, probe. It's a sort of fine periosteum elevator in the shape of a hockey.
Okay.
See where I'm pushing it? Underneath the bony margins, Underneath the bony margin to make it stuck. देना छोटा छोटा दे. See all around underneath the bony margins, and this is required here. This Surgicel serves many purposes. It gives a tough material to deal with rather than a fat, number one, to help manipulating the fat. Number two, it helps inducing the fibrosis. See this? I can push my fat better with the help of Surgicel.
It holds the fat also, sir.
Yes, sir.
It is pushing everywhere underneath the bony margins. See that? It is already stuck. Self-holding. Can you see? Underneath the bony margins, self-holding. That is what I wanted to make. So this bony margin is helping me holding the fat. See very clearly? Can you see clearly?
Yes, sir.
Yes, yes, yes.
See now, completely holding the fat.
Sir, Dr. Manish Munjal wants to know, do you make the entire underlying bone raw before putting the harad?
Yes, yes. I don't want any bony spicules, projecting. Now, once it is done, I will use the Merocel.
Suppose the patient has two defects, bony, or you can say bony crest in between two defects. Would you make it single one, or would you repair?
Yeah, if they are close by, you can make single one. Sometimes you have multiple defects at distant areas.
This is a good point. The Surgicel can making the life easy.
Surgicel is very useful in holding the fat.
It doesn't allow the fat to squeeze out from the other area where you apply the pressure.
Can you see now?
Yeah.
Yes, sir. Yes.
Completely compressed, and it is holding itself. See, on its own. Now I'll be using a little bit of the tissue glue here.
Yeah.
Just to hold the things in place,
Dr. Satish, as Rajiv said, there are multiple bony defects. If you repair separately, will you apply the same hub flap covering all?
Pardon? Can you repeat, sir?
As there are multiple openings, as Rajiv pointed out, you said separately do it. If they are far apart to cover overall, you use the same Hazard flap to cover all the defects.
Yes.
Yes.
If there are multiple defects, is an indication for the flap.
Yes.
See, any complex situation, anything making complex, better to use a flap.
Yes.
There is no harm in using flap, but the additional time you need, that's it. How much did the flap take additionally? 5 to 10 minutes.
Yeah.
This raw area will heal on its own quickly in few weeks.
Yeah. No, you are converting it to a primary healing rather than a secondary healing by fibrosis,
Yes.
by putting a vascularized flap.
Yes. So primary healing will take place at the site of the defect.
Right.
Where we want.
Yes.
I don't want any infection because of the secondary healing.
Yeah.
Secondary healing can take place at the nasal septum without any problem.
Yes.
How little we can repair the endoscopically? Like, can we repair a very high lateral orbital defect endoscopically? I think we can.
So I use another Surgicel. I always use Surgicel to manipulate my fat. See this little bit of the glue?
Yes.
This little bit of the glue is additionally to hold the things which are placed in your area. See now, everything engrossed.
Yes, sir.
I can see my frontal opening very clear. And now last thing.
Is the flap.
Yeah, this is the amazing thing. See, everything ready-made, surfacing, ready-made, mucosal covering, everything there being ready-made, that to vascularize.
Yes.
There is no comparison to it. See now? And I will be
Beautiful.
covering all those critical areas, not only the areas, but beyond. Beyond that. Beyond the margins of the... See everywhere?
Yeah.
See, it is holding so well. Covering so well. Can you see? Hello?
Yes, we can see that.
Yes, Dr.
This is my sphenoid sinus, that is my frontal sinus. And here I'll take the opportunity to put a stent, temporary stent. See, no?
Yeah.
What happens? I'll be using some more glue, some gel form and all that. I will say it can block my frontal sinus opening, you know?
Yeah.
And can lead to frontal sinusitis, which I never want. So what I will do? This pack I am going to leave for few days, and meantime, I will leave a temporary stent into the frontal sinus like this.
How long will you keep it, sir?
This is simple drip set tube.
No, how long will you retain it? Will you remove it after 1 week? Or...
With the pack.
Days. 5 to 7
After
days.
5 days, five,
Yeah.
6 days.
It's actually just a mechanical device to keep the flap from going to the front.
Yes,
it's not
yes.
technically a stent, yeah.
To keep the frontal recess open.
Open, yeah.
And I think more important is,
Pardon?
Dr. Satish said very correctly, you will be putting glue, blah, blah, blah. So nothing should be getting into those openings and blocking it intraoperatively.
Yes. See, at this point of time only, I want to pass this tube before I fix my flap.
Yes.
It can easily block the frontal. See how big the flap is.
Yeah.
Going beyond the anterior margin of the defect. This patient has a narrow frontal sinus opening. See that?
Yeah.
And I want this to remain open. छोटा है क्या थोड़ा? छोटा है. Give me a bigger tube. थोड़ी bigger. पतली दो ना यार. बहुत मोटी है.
Will you remove the tube under endoscopic guidance or you just put it in OPD?
While you remove the other things.
Okay.
Simple.
Because my only fear is when you pull the tube, the entire flap moves and the...
Yeah, you have to be very careful while passing this tube. See, my tube is already going in the frontal. Can you see?
Yeah.
Can you see that?
Yeah, nicely.
Yeah.
And the other end of the tube I will park in the maxillary sinus.
Okay.
That's it.
Yeah.
So that will give me a sense of security that my frontal will not get blocked. See now.
Yeah.
Beautiful.
See, my skull base repair is away from the frontal sinus drainage pathway.
Yeah.
Can you see my sphenoid is already away?
Yeah.
And see, this is without any pressure, without any stretch. It is like this will heal this area of the defect primarily in no time. Can you see?
Yeah. Yeah.
Any doubts?
The idea of putting the tube into the frontal to maxillary is fantastic because no tube comes out of the nose.
Yes.
So
now my last is the remaining, I will keep this flap in position by using this glue.
yeah. Dr. Satish, just a very theoretical question. Have you ever come across a Haddad flap by rotation has caused necrosis? Like in asopas for hypospadias, the main problem is the rotation of the flap. In the rotation, that kinks the vessel.
Yes.
So in Haddad, it is so wide based. Have you ever seen by amateurs like me or anybody doing it and that leads to necrosis of the graft? Have you ever seen it?
Touch would not, but yes, you have to be careful. That's why while raising the flap itself,
Yeah.
you first take to the area where it is required,
Yes.
unroll it and keep it like this so that you can again unroll.
Yeah.
Unroll and then unroll. It will not give any problem. See now,
Because, yeah.
what I am doing. Now I am least bothered about my frontal. See now?
Yeah.
Imagine had I not placed this tube in the frontal, it would have blocked my frontal completely.
Yes.
Now imagine the situation. You have repaired the CSF leak at the level of the ethmoidal roof and given the frontal sinusitis. How will you deal with that? This will be most complicated a situation to
Yeah.
deal with the frontal sinusitis in the vicinity of the skull base defect repair.
Yeah.
See now, this
Yes,
is my gel form to hold everything, to press on everything, which I am now soaking into my ciprofloxacin dexamethasone drops.
Yeah.
This swells up and exert more pressure, even pressure everywhere. Can you see now?
Yes. Yes.
This is 70 degree what I'm using. What I'm using is a 70 degree.
Yeah.
What you can make out, no bleeding. That is the site of the choana. That is the tube, the maxillary sinus where it is parked here.
Yeah.
That is going to the frontal. Your flap is behind the, see this?
Yes. Yes.
Very well compressed in position, see that?
Yeah.
Check everything in order, see this? Completely compressed.
Yeah. Yeah.
See the frontal from above that. And now will be the final repair. Give me a small piece of, what I will do. I will compress this with the marrow cell to keep it for few days. But my concern is while I remove the marrow cell, my marrow cell can stick to this, gel form.
Yeah.
And bring everything out. What I have done, I have interposed this silastic.
Yes.
I have wrapped my marrow cell into the silastic. So once I remove the marrow cell, the rest of the layers will not disturb.
Yeah.
Remove. Give me a small. remove this. I will put it again.
One of the delegates wants to know your experience with Duragen, sir.
Experience?
With Duragen, artificial Dura. Do you use that?
Not really. I have used earlier, no reservations, but not using it regularly. I will pass this silastic tube separately first. I don't want to disturb the underlying layers. My role of interposing this, something which is not adhesive is to prevent my seal, what I have put inside, to get disturbed while removing the marrow. See now? No. I want the even pressure of the marrow cell onto the
skull base,
onto the gel form. This gel form is exerting even pressure on the flap, and that is exerting the even pressure on the fat which I have placed and on the skull base. See that? Now everything in order. See now. This is what I have placed is a marrow cell which we will remove. I will keep it for few days. See, this being a revision situation, you are not supposed to take any chance. Now see, once it is swollen up, this is swollen with the betadine, povidone iodine. So what we use the antibiotics in order, first the rifampicin, wherein we soak the fat. Then we use the ciprofloxacin to soak the gel form, and now the povidone iodine to soak the marrow cell, 0 degree.
So the technique of dipping the fat in rifampicin, is it based on some literature or is by your experience?
Yes. It is based on a literature, studies done to prevent the lysis of the fat by infection, by airborne infection, whatever. If fat which is in contact, see now everything is kept with pressure right onto the anterior nair, so nothing will disturb. See now, till here. Okay. So right from the skull base to the anterior nairs, we have splinted completely. So the idea of using the rifampicin to soak the fat is to prevent the staph infection, which is the commonest airborne infection and which is the commonest infection leading to lysis of the fat, which is in contact with the brain tissue. If that happens to get lysed, happen to get infected, the chances of meningitis are more. So it is always better.
Because I've seen Professor Wormal using human egg trap to decrease the BMR of the fat.
So right from the anterior nairs to the skull base, there is complete splint, multi-layer. My initial layer in contact with the cerebral tissue was the fat, which I kept in place, pressed with the Surgicel and holding in place with the glue. Then covered completely all around, a centimeter around, with the vascularized flap, which held in place with the glue, and then with the gel form soaked in ciprofloxacin. Then everything was pressed till anterior nairs by marrow cells soaked in povidone iodine. So that's something, a complete splint is.
And a stent for the frontal sinus?
Skull base to the anterior nairs, nothing can disturb it. No bombardment can disturb it.
Yeah.
And all the sinuses at the same time have been thoroughly kept, visualized and kept open. The maxillary frontal taken care of by the, the tube, and the sphenoid widened and seen under vision. The flap was going around the sphenoid, not blocking it. So this is what one can think of giving a better outcome and preventing complications. So both the things are required at the same time.
Yeah.
It is a fantastic demonstration, sir. We really enjoyed it. Fantastic
Thank
demonstration.
you. Any comments, any suggestion, anything you do differently?
No, I'd like to ask the question once again because Professor Palaniyappan sir has asked it again. The coablator setting on skull base. Many are asking about the same question.
Yes, the coablator setting at the skull base is full setting. I have a habit of using the coablator at the skull base extensively, and I keep on the highest setting. But yes, you have to be careful while increasing the setting of the ablation mode. Ablation is dangerous, Coabulation is not dangerous. Ablation is dangerous. So be careful while ablating. It can cut through the vessels. It can cut through the vital structures. It should be kept on the lower side, staying very, very careful. Any questions, or do we go ahead? So, do we go ahead with the next case?
Yes, sir.
Yes, yes.
So, the next, as I said, is a biopsy-proven olfactory neuroblastoma. Olfactory neuroblastoma is not a very common tumor, but amongst the sinonasal malignancies, one of the important variety of tumor. Sinonasal is the area for malignant lesions, which I would say, as far as the diversity of the histology is concerned, if you take in comparison to the other areas, every square inch of the sinonasal area has the ability to give most diverse histologies as compared to any other area in the body. So many histological variety of cancers have been found in the sinonasal areas, and now the time is the histology driven treatment. If you go through a landmark publication by Paul Casanova, histology driven treatment of the sinonasal malignancies, which is mind blowing, and it is true because all these different histologies of tumors have different biological behaviors, needing different treatment, having different response to the different treatment protocols, and having different prognosis. So reaching to a correct diagnosis is a challenge, and this calls for a dedicated pathologist, experience, and a dedicated pathologist with immunohistochemistry methods and all that, which we'll discuss. So first of all, about the case details, I welcome here Dr. Pankaj Gupta, boss, our neurosurgeon, with us now. So first of all, this patient's CT scan. See, as I told you, this is a biopsy-proven lesion. Now on CT scan, what do you say to this lesion? This lesion occupying the nasal cavity, extending to the orbit, extending to the intracranial space, breaking the barriers, extending to the across the other side. It looks like a tumor, as simple as that. But what kind of a tumor it is, you can't make out from CT scan. CT can give you bony details. CT can give you the information of breaking the barriers, but it can't give you soft tissue details. So in order to get the soft tissue details, what else you get from the CT scan? If I come from most anterior, let me come from most anterior. See, this part of the frontonasal process, everything intact. The frontal sinuses are not very big. That is something, a negative factor. I'll tell you why. Then the orbit. This lamina is gone. And from CT scan, we can't make out whether the tumor has gone intraorbitally or not. Whether it is pushed the orbit or gone intraorbitally, you can't make out with a CT scan. For that, you need an MRI.
Yes, sir.
Then as you go behind, see the skull base completely gone and the tumor is going up and down, through and through. All this septum is broken. See, only the lower part of the septum is intact. You can see. I will show you better on MRI. The upper part is through and through with the tumor. And as you go behind, this is the sphenoid sinus. You can't make out what is there in the sphenoid sinus, wherever it is, whether there is tumor, whether there is secretions. Everything is opacity, what you see on CT scan. And in order to get details, what you need is an MRI with different sequences, which I'm going to show you. And there is no, I would say the barriers broken in the sphenoids to go beyond. This is what you get from the CT scan. And you can't get much information from the CT scan more than that. Now, coming to the MRI, with various sequences of the MRI, which I'm going to show you, you can make out all the details. First of all, this is T2 weighted MRI, one of the most useful sequence. If I come from anterior to posterior, we have discussed earlier several times. On T2 weighted, the secretions will appear bright, and the tumor, which is more cellular, which will appear hypodense. Now, look at the MRI. If I come from anterior to posterior, this hypodensity, this mass lesion, see this mass lesion, entire mass lesion.
Yes, sir.
This lower part of the septum is protected. See this?
Yes.
See what is there in the maxillary sinus, hyperintense.
Sinusitis secretions.
This is blocked sinus. Because of that, this is all pent-up secretions in the sinus. This is not tumor. Tumor you can see here. And what you see at the level of the orbital margin, see level of the orbit, see on the periphery everywhere, that is classical of olfactory neuroblastoma. I can say with this MRI, without even the histology, that it is olfactory neuroblastoma of this classically giving the cyst on the periphery of the tumor, particularly superiorly, a cyst on the periphery of the tumor. See this hyperintense area?
Yes, sir.
These are cysts. And on the intracranial surface, if you have cyst of such tumor, which is in the midline, passing to the cribriform, it can't be any other than olfactory neuroblastoma. That is classical sign. Now look at the orbital surface. See all this cystic lesion with a well-defined margin. Can you see? It is not infiltrating anywhere.
Yes, sir.
It is pushing. By the way, olfactory neuroblastomas, by and large, in the beginning, I would say, are orbital sparing. Unless very advanced, they do not infiltrate into the orbit. They go up and down across the cribriform, intracranially down in the nasal cavity, but rarely go laterally to invade into the orbit. They can push, but they don't really invade in the beginning of the course. In the very late situation, they happen to invade the orbit, and then it's a altogether different situation warranting orbital exentration. So here, if I go behind, see now in the sphenoid, what is there in the sphenoid?
Secretions.
So everywhere, wherever is the secretions, it is hyperintense on T2.
Yes, sir.
Whereas if the tumor, it is hypointense on T2. And now let's bring the contrast in picture. That will make it more clearer. Let me bring the contrast. Yes. This is a 3D contrast. This is the coronal one I am bringing. Now see. I hope the picture is clear.
Very clear.
Now wherever are the secretions will not enhance on contrast.
Yes, sir.
Got my point?
Yes.
Wherever is the tumor will enhance on contrast. Just opposite T2 to confirm what you have seen on T2. Now see the secretions in the maxillary sinus. Can you see?
Yes, sir. Hypointense.
Which were hyperintense on T2.
T2.
Hypointense on contrast are definitely secretions. Okay?
Yes, sir. Yes.
Number one. Number two, this is entire tumor which is enhancing. And this tumor, the cyst on the superior surface of the tumor. Can you see that?
Yes, sir.
It is not enhancing.
Yes.
See that? All cystic areas do not enhance. All cystic areas are bright on T2.
Yes, sir.
See?
Yes.
And this is the part of the tumor which is projecting intracranially.
Yes.
See this? What tumor is projecting intracranially through and through? That is breaching the cribriform area. Why I am saying breaching? Let's come anteriorly. See this anteriorly. This is a hypodense line of the skull base. Can you see all the way?
Yes, sir.
That is the complete hypodense line of the skull base. Now, as we go behind, now see what is happening. It is breached. Can you see?
Yes.
It is completely breached. You can see the hypodense line on either side, but in the center, it is breached by the tumor. Tumor has invaded the dura and the tumor has gone intracranial. This invasion of the dura is justified by this nodular thickening of the dura. It's not a linear thickening. Linear thickening could be because of inflammation, but nodular thickening is classical of tumor. See this? And
Yes, sir.
hypodense line is completely gone through and through. There's no hypodense line. You can see the hypodense line of the skull base on either side, but in the center, the tumor is through and through, involved the dura and gone intracranially. This is what we wanted to see, the extension of the tumor. Can you see very clear?
Yes, sir. Sir, can you tell the features of fungal sinusitis on T2 weighted MRI with contrast? How to differentiate with that?
Yes. It will look similar in the sense, not similar, not exactly similar, but similar in the sense, on T2 weighted, the fungus will be signal loss, complete signal loss, dark.
Okay.
This is hypodensity. And the fungus will variably enhance according to the vascularity and necrotic areas on contrast. So that is different. It looks same like hypodensity on T2 and enhancement on contrast, but that hypodensity is not like this kind of hypodensity. That will be complete signal loss.
Okay.
See this intraorbital structure. There is a plane between the muscle and the tumor. It is pushing, not infiltrating. Can you see that?
Yes, sir.
Yes. This is a very, very important thing for decision making. You know, in the past, involvement of the periorbita was a straightforward indication for orbital exentration. Straightforward. Then, with the advancement in the imaging technology, advancement in the this thing, endoscopic technology, availability of the frozen section, it has enabled us to evaluate the periorbita involvement thoroughly. You can evaluate with the endoscope intraoperatively when the periorbita is invaded. Even if it is invaded, you can resect wide under endoscopic guidance without needing an orbital exentration. You can preserve the orbit in many of the cases which would otherwise be sacrificed in the past. What my point? So here, if the tumor is involving the periorbita, to me still is an indication for orbital preservation. I can endoscopically preserve the orbit. If the periorbita is invaded, you can go endoscopically and widely resect the periorbita, send for the frozen section for the margin, and you can go at endoscopic.
Yes, sir.
Second, beyond that, even if the tumor has transgressed the periorbita and invaded the orbital fat, not extensively to involve the orbital muscle, still you can, preserve the orbit and remove it widely endoscopically.
Sir, Dr. Riaz Afridi from Peshawar wants to know, can we know the exact origin of olfactory neuroblastoma?
Yes. See, this tumor arises from the superior part of the nasal cavity in the region of the olfactory epithelium. For limited lesions, you can go to the site of origin very easily. But for such advanced lesions, still intraoperatively, I will show you the site of origin. That will be our protocol for this endoscopic surgery. We will do the debulking of the luminal component, and through that debulking, we will reach to the area of invasion. That is the site of origin. And then we will resect it wide with the free margins. With frozen section free margins, we'll resect it, and it will have the same impact as any en bloc surgery.
Yes,
this
sir.
you may call piecemeal, but piecemeal for the luminal component, not for the attachment. For attachment, it is as radical as en bloc resection, as you are removing the attachment wide with free margins. And all the studies have compared equal results. Rather, certain studies have given better results with endoscopic, as it offers better visualization and magnification. So that we'll discuss this technical part
Yes,
intraoperatively.
And sir, please tell the indication for radiotherapy in these cases.
See, if you look at the stage of this tumor, to me it is stage 4 tumor by all classification. I will enumerate the classifications after this. So for all these advanced tumor, the treatment is radical surgery followed by radiotherapy. That is the standard of care for all these advanced tumors. So obviously for T1, T2 lesion, you may think of a radical excision, void excision, endoscopic excision with free margins, and you can follow them without radiation therapy under close follow-up. But for such advanced lesion, obviously you have to follow with the radiation therapy always. And see, the involvement of the brain, that is most important. This is T4, stage 4, where the tumor has transgressed the dura and gone intracranial, very, very clear. So
Sir,
this is
yes,
sir, please.
Sir, Dr. Vivek Rajan wants to know, can you tell us, sir, whether lamina is breached or pushed intraorbitally? How can we know?
Yes. I will give you the best thing. That's what I was coming to. And that is something we always recommend now, to get a diffusion weighted MRI done.
Yes, sir.
Let me show you. See, what is diffusion weighted for everyone who have not heard earlier in our previous webinars, I have mentioned several times. It is a bioimaging. Bioimaging means this MRI creates a magnetic field environment between the magnets. So this diffusion weighted MRI assesses the diffusion of water molecules in the tissues. So tissues having more water content will freely diffuse, high diffusion. Tissues having less water content will diffuse less. So tumors having more nuclear cytoplasmic ratio will have less diffusion. More cellularity will have less diffusion. Inflammation, infection with more water content will show good diffusion. Got my point?
Yes, sir.
Now see, this is diffusion weighted imaging. I am coming to the tumor site. Can you see this area?
Yes, sir. Completely dark.
This is diffusion restriction where the tumor is.
Yes, yes.
And whatever in the surrounding, see what we see on the tumor all around. In the surrounding is the inflammation.
Yes, sir.
See, this whitish is the
inflammation and secretions.
Yes. Now see at this surface, orbital surface, what you see? See very clearly. This is my prime weapon to know whether it is invasive front, infiltrative front, or compressive front.
Yes, yes.
Now see, this is orbital surface. Can you see all the way?
Yes, sir. Beautiful.
What is the front? Inflammatory. Can you see?
Yes, sir. Yes.
Tumor which is showing diffusion restriction is not infiltrating into the orbit.
Yes, yes.
Front is not infiltrative. You can see very well. It is pushing. See, the orbital structures are pushed all the way.
Very clear, sir. We can see the demarcation.
And see this diffusion, no restriction. So see, everywhere along the orbital front, there is no diffusion restriction. The tumor is here. And see behind in the sphenoid sinus, what is there?
Secretions.
Secretion showing huge diffusion.
Huge diffusion.
So wherever the restriction is the tumor. And this is the best way to make out how your fronts are. This is so important in decision making. If had this tumor been infiltrating into the orbit, I would not go with endoscopic. That is an absolute contraindication when you need an orbital clearance. You know?
Yes, sir.
And then two kinds of procedures are warranted. Either orbital clearance or orbital exentration. There are two different terminologies. Make it very clear. Orbital clearance means clearance of the entire orbital content without eyelids. And exentration with eyelids. When the eyelids are involved, it is called exentration. When you spare them, not involved, not remove, then it is orbital clearance. And both these procedures are, when warranted, the endoscopy is something out of question.
Yes, sir.
So, yes, there's a question from Pankaj Boss here, whether there is pial invasion above whether there is pile invasion of the brain. I don't think there is pile invasion because I don't see any surrounding brain edema. Can you see here? There is no surrounding brain edema of the intracranial part. That rules out pile invasion. Got my point? That rules out true brain tissue invasion. It is going intracranially, but not invading the brain tissue. And this is one of the favorable factors. Why this is so important here? You know, you go to the literature about the patterns of recurrence of the olfactory neuroblastomas going intracranial. One of the commonest pattern is not distant metastasis or regional metastasis into the neck. Of all these tumors going intracranial operated by any means, endoscopic or craniotomy, whatever, one of the commonest pattern of spread is intracranial leptomeningeal spread. And that happens mostly when there is pile invasion and you are not able to clear the margins completely, because once it invades the brain tissue, you can't make out. And that is one of the disaster when your patient faces leptomeningeal spread. Then you can't do anything but to give the adjuvant therapy by means of chemo and radiotherapy. And that is a most difficult situation one can think of. So one of the issue was orbital, which we have addressed. Another issue is intracranial. Once this goes intracranial, you have to remove the skull base thoroughly. We are doing endoscopy. This is not a contraindication to endoscopy. Intracranial extension is not a contraindication to endoscopy. Wherever it goes, it is the pile invasion, true brain tissue invasion, which makes you think twice before going by the endoscopic approach. Number one. Any orbital soft tissue involvement, muscle or beyond, intraorbital content, muscle, beyond, orbital apex, optic nerve, you know, the eyelids, sclera, whatever involved, it warrants external approach. Any, you know, soft tissue, anterior soft tissue involvement with the frontal sinus bone or soft tissue involvement warrants external approach. It's not contraindication.
Okay, Satish, can I ask a question?
Yes, please.
Satish, you said that this is a histology proven olfactory neuroblastoma. Now, have you done the Hyams grading? And if at all you have done it, would that change your approach, or you would still stick to your endoscopic approach? Or would you be more aggressive in certain instances?
Can you repeat? I could hear part of it, Naren.
I'm saying that have you done a Hyams grading, and would that change your approach, surgical approach?
Yeah. Yes. Hyams grading is important. Your question is valid, Narayan. Good question. Hyams grading is done for prognostication. So it gives you in your mind, if you can prognostic your patient, you can tell your patient about the consequences, but it doesn't really change your approach. It changes your, you know, overall protocol in terms of inclusion or exclusion of the adjuvant therapy.
Correct.
Not the surgical approach.
Correct, correct.
In higher Hyams grading, like this patient, it's Hyams grading 3, will require adjuvant therapy. For Hyams grading 1 or 2, with a limited lesion, you can avoid adjuvant chemo radiation therapy. That is what something you can prognosticate with a higher Hyams grading. They are more and more undifferentiated carcinomas rather than olfactory neuroblastoma. Goes to one. It is so difficult to, you know, histologically segregate from undifferentiate from neuroendocrine carcinoma these olfactory neuroblastoma. I am coming to that through some slides.
So Satish, that makes that.
Yes.
Satish, that gets us to the second question. Suppose this was a Hyams grade 1 and you had got a good excision, or Hyams grading 2, for example, and you had got a very good excision margin. Would this patient still be subjected to radiotherapy, or what would be your protocol?
If you have negative margins, with Hyams grading 2, I would not go. Okay. I would observe.
Okay. Serial MRIs.
Hyams grading 3 or 4, or Morita or Dulgrave grading 3 or 4, I will always add on radiation therapy post. Not neck dissection. Neck dissection only when there are positive lymph nodes. Only when you are irradiating, you have an N0 neck, but you are irradiating post-operatively the primary. You will include the neck for the radiation. Got my point?
Yes, Satish.
Not prophylactically.
Sir, what are the indications of pre-op-adjuvant therapy, sir? When do you give pre-op-adjuvant and then take the patient for surgery?
Yeah, pre-op neoadjuvant therapy.
Yeah.
Once you have a tumor which looks unresectable, which is going beyond your limits of resection, you can control, you can reduce the tumor by means of giving neoadjuvant chemotherapy. If it happens to control the tumor, reduce the tumor, it can make it resectable. Number one. Number two, you can prognosticate by the same means. Tumor which are responding well to the neoadjuvant radiotherapy have by and large overall good prognosis as compared to the non-responders. So this strategy of neoadjuvant radiotherapy is sometimes used as an organ preservation strategy. Sometimes you have a tumor breaching into the orbit, and you are in the fix of either orbital clearance for doing it or not doing it. You can, in those situations, give a neoadjuvant chemotherapy to reduce the tumor and make it very well endoscopically resectable, and then follow with the post-operative chemoradiotherapy. This is important.
But I think Satish, you must add one thing: the resection margins. Once you're using neoadjuvant chemotherapy, how wide would be your resection margins?
Ideally, it should be the pre-neoadjuvant therapy margins.
Correct.
Ideally. But here, once it comes to organ preservation, orbital preservation, you have to compromise. And you can do this. This strategy you can do in lower grade malignancies. You can think of doing in olfactory neuroblastoma, but I would never do in sinonasal undifferentiated carcinoma, small cell carcinoma, neuroendocrine carcinoma, which are more virulent cancers as compared to in this range of all these neuroendocrine tumors. Olfactory neuroblastoma is the most favorable one as compared to the others. As far as the prognosis, as far as the final outcome is concerned, the survival is concerned, the best is with the olfactory neuroblastoma.
Yes, Satish.
Anything more on the radiology you want me to?
No, I think everything is quite clear.
So this is the discussion on the relevant sequences required. Again, I would say the onus is on us to order the relevant sequences. It's not that the MRI brain, the radiologist may not do the diffusion, radiologist may not do a good 3D contrast. My 3D contrast, let me show you. This is so amazing. Let me tell you, you can see your tumor three-dimensionally. See this contrast sequence is 1 mm. It is generally the radiologists don't give 1 mm contrast. It's 3 or 4 mm. And 3 or 4 mm is not so useful in these critical areas. And that to 3D. See now, each and every area you can reconstruct, you can take your cursor and see everywhere, wherever it is. See this, how this tumor is involving the dura. Can you see this? Yeah. What area of the dura is involved? See this.
The bristles.
From behind the frontal sinus, from here till just anterior to the sphenoid sinus. Can you see?
Yes.
And this part of the dura I am going to resect. This thickened dura, that this nodular thickening is suggestive of infiltration. Not the entire dura, not this linear thickening is suggestive of infiltration. So my dural margin of resection would be right from behind the caudal limit of the frontal sinus to the proximal limit of the sphenoid sinus. And similarly, in the lateral limits, my lateral limit would be right from lamina paprica to the lamina paprica, orbit to orbit, medial to lateral, and anterior to posterior from frontal to the sphenoid sinus. Our strategy would be to open up all sinuses going around the tumor, to debulk the tumor, to truncate it to the site of attachment, then drill the surrounding skull base right from orbit to orbit, from frontal to sphenoid, and then see the dural margins involved. And going beyond that, we'll do an internal craniotomy. We'll cut the dura, go inside and remove the tumor under vision. This is going to be the whole plan. Difficulty is number one regarding the availability of the hard flap. I'm too concerned about this case regarding the availability of the hard flap. The reason is, see this. See, this is nasal septum. Can you see?
Yes, sir.
Can you see this opposite side nasoseptal flap is intact anteriorly? If I start from anterior, see this here. This septum flap is intact. As I go behind, it is intact till here in the lower half. In the upper half, it is through and through the septum. You can see very clear.
Yes, sir.
So all the way behind, see this till the nasopharynx. What I am hoping is the lower part of the hadad I will get. That, not the upper part. Now to get a wide flap, what I will do, to get a wide flap, I will, besides this lower part of the hadad, I will include the floor of the nose. I may include, to give a breadth to it, the meatus, the inferior meatal flap, and make it as wide as the nasoseptal flap. This kind of modification is required. Everything can be planned on the basis of MRI. See, you have to be prepared with all this information from MRI. And in case intraoperatively I find still that I may implant the tumor, the flap is not looking good, finding infiltrated, I will not think twice and bring in the pericranial flap from above.
Yes, sir.
Okay.
Sir, can you throw some light on gene therapy and pre-adjuvant chemotherapy in this case?
Neoadjuvant we have already discussed, Udbhav.
Yes, yes.
Neoadjuvant is a good, thinking in large tumors, borderline resectable tumors, unresectable tumors. You can plan of giving neoadjuvant radiotherapy to downstage the tumor to make them resectable. Tumors which are borderline, warranting orbital exentration, you can make them, downstage them to preserve the orbit. That is the whole strategy behind neoadjuvant chemotherapy.
Yes, sir. So I think we have covered most of the
core treatment is surgery.
Yes, sir.
All this is adjuvant. Now coming to the what Narayan was asking, let me about this tumor, certain facts about this tumor. This we have discussed earlier. Immunohistochemistry is very important to differentiate from other sinonasal malignancies. Like I mentioned, these are the specific immunomarkers which olfactory neuroblastoma reacts to, which is specific for the olfactory neuroblastoma, particularly calretinine and negativity to P63 are clear markers. You have to have a good pathologist and a backup from the pathology side for the marker. So these are all tumors looking similar on histopathology to olfactory neuroblastoma. All these tumors have hallmark of small round blue cells. All these tumors have small round blue cells. It can be anything, and majority of the times you can't differentiate from a simple histopathology and you need the help of immunomarkers. 30% of the time your diagnosis changes on immunomarkers. It is so high. 30% of the time. That's why such patient warrants immunomarker study to reach to a correct diagnosis, because all these pathologies have a different tumor biology, different treatment protocol, different prognosis, different outcome. Got my point?
Yes, sir.
Like nut midline carcinoma is a very, very aggressive tumor. Like sinonasal undifferentiated carcinoma, I said on the other side of the spectrum is a highly aggressive tumor, warranting every possible aggressive therapy. So all these tumors have a different rhabdomyosarcoma, wherein the primary treatment nowadays, unless it is very good resectable with no morbidity, otherwise the primary treatment is a chemotherapy, and surgery is reserved for the either the untreated portion, not responders, or the other recurrences. Lymphomas are solely the medically treatable pathology. So all these look alike on histology because of the small round blue cells. What you all need to reach a correct diagnosis is a immunomarker studies. We discussed about the Kaddish last time, and this is all the staging methods, Morita, Kaddish, and the Dulgrove. And this is important. The Hayams, what Narayan was asking, is a good histological grading system. As the histological grade 3 or 4 reach, it becomes more and more undifferentiated, more aggressive, requiring more adjuvant therapy, and you can counsel your patient for the more poorer prognosis. This is so important. Pre-operative, you need to have a good tissue, good amount of tissues for all this immunomarker study and grading system. And there are a variety of pathologies in this region. We'll see rest next with the other case, that is sinonasal carcinoma.
Sir, Dr. Aditya wants to know any tips for taking biopsy in these cases, from where to take, what instrument to use.
I always direct the biopsy MRI guided.
Okay.
The reason is I want to take the representative tissue, not the peripheral, inflammatory tissue.
Okay.
Diffusion weighted MRI will tell you where exactly is the restriction, which is more likelihood of a tumor to take you to the right area for biopsy.
And sir, he wants to know, do you use cobblator during any biopsy, while taking biopsy?
Not really, not required.
No, yeah.
Not required. Narayan, unmute.
Narayan sir, you have to unmute.
Yeah, I'm sorry. Satish, I said you can go on to the live surgery.
Okay, dear. Thank you. We can discuss anything left.
So, Udbhav, are there any more questions?
Sir, can you throw some light on gene therapy? Is there any indication for gene therapy in these cases?
Not really. So many things are investigational, particularly the immunotherapy.
Yes.
More and more understanding of the cancer, the molecular pathways.
Yes, sir.
More and more targets are being identified.
Yes, sir. Yes.
So the targeted therapy is a revolution.
That is what we call immunochemotherapy nowadays, isn't it, Satish?
Yes, sir.
Yeah.
So after surgery, when you recommend to go for chemoradiation in these cases, Dr. Gansal? Hello?
Yeah?
After the surgery, when you recommend to start the chemoradiation in these cases?
So, like we discussed, the radiotherapy is required for the high-grade tumors, high grading, for the advanced stage tumors, for tumors with intracranial spread. Along with the chemotherapy is added if there is any lymphovascular invasion, perineural invasion, or positive margins. Then you add on chemotherapy as well.
So the decision will be taken after biopsy, sir, after the information you get via biopsy.
Yes. As usual.
Yes, sir.
Chemotherapy is added when all these, high-risk features are available on the post of histopathology.
Yes, sir. Yes.
Dr. Satish, any role for gamma knife to reduce the mass or vascularity, anything? I don't think, no?
Not at all.
Not at all, yeah.
With this kind of a tumor, gamma knife is...
Yeah.
It's just
Volume बढ़ाए. So it's a teamwork, and the team includes obviously the ENT surgeon. Hello?
Satish, we are hearing.
Okay. So the team includes the ENT surgeon, neurosurgeon, the intensivist, the radiologist, the pathologist, the intervention radiologist sometime in many of the skull-based lesions, then the neurologist sometimes and the post-operatively for the neurological conditions. So it's a teamwork.
Yeah.
Now, are you getting the endoscopic picture?
No.
Not yet.
Not yet. Your screen share has to go first, probably. Yeah.
Satish, you also mentioned that this frontal sinus is not very pneumatic. You want us to throw some light on why?
What?
You also mentioned that this frontal sinus was not very pneumatic, and that's a disadvantage, correct? So you show that, right?
Frontal sinus, yes. Yes, Narayan. So, see, in this transcribiform approach, for the anterior part of the tumor, you many a times you have to add on a draft 3. To expose the posterior table of the frontal sinus, you have to do a draft 3. In more anteriorly placed tumors, in a good, pneumatized frontal sinus, it is much easier. In the smaller frontal sinus, the draft 3 again is an additional challenge to, to maintain the patency of the draft post-operatively.
Right.
Addition of the draft 3 improves your anterior exposure. You can remove more and more posterior table of the frontal sinus to go more and more anteriorly. Like, for example, this kind of exposure which we are going to get, if we remove the posterior table, generally from the posterior end of the frontal sinus to the anterior end of the sphenoid sinus roof is generally 3 centimeters. If I do a draft, I can remove more than 1 centimeter of the posterior table to make this, exposure more than 4 centimeter. Got my point? So the draft 3 is a usual addition, very useful addition, I would say, whenever required. But if you have a pneumatized, sinus, it is always beneficial, advantage. See the opposite side?
Yes, sir.
I know inferiorly, I have a good, space. I have a good normal nasoseptal area to harvest for the flap, but superiorly is a big challenge because we know superiorly tumor is going through and through the septum. See that? It is contained in the septum superiorly. Can you see?
Yeah.
There is tumor.
Yes, sir.
You can see the bulge. But inferiorly I can preserve, and that is what I need to do. I may have to take the, the floor also. I want to include into the resection, so I have to do something to improve my exposure. Because, see this, with the tumor pushing on the septum, with the turbinates coming in the view, there is hardly any exposure. And anywhere in the endoscopic surgery, we are going with a poor exposure, you are likely to go in problems. So we have to do something to improve our exposure, okay? On this side, see this tumor?
Yeah.
Our goal is to truncate the tumor to the site of attachment with luminal debulking. And since it is a vascular tumor, you have to, be prepared with that. The vascularity is mostly coming from the ethmoidal vessels, which ultimately, when we reach to the skull base, we will coagulate the vessels. But here, let me show you. See the opposite side, luminal debulking. See, my assistant is giving irrigation, simultaneous irrigation, to maintain my visualization.
Yeah.
And debrider is the preferred tool to expedite the process.
There is no need of carpet coagulation in these cases, like you do in many cases, the carpet coagulation before debriding.
No. See, this is a tumor tissue with diffuse vascularity. It's not an encapsulated tumor.
Yes.
The surface coagulation alone is not going to work. Unless you control the vessel, you have to face this. Go fast, debride, pack, and then come back.
Yeah.
See this involvement of the septum above.
Yes.
That is what I want to see.
So if you don't have a good septal flap or a Hadad flap, would you do a free flap repair?
No, I will take pericranial.
Okay.
I will bring in the pericranial.
All right.
That's the next easiest flap from outside. Let's see if our Hadad remains adequate or not for this. Then we'll take a call. See what I'm trying to see, the involvement of the septum. This tumor is pushing the septum to the opposite side, which I want to debride. See involvement of the septum?
Yes, yes.
See going through the septum to the opposite side?
Yeah.
Give me 40. Give me 40 blade. See how it was transgressing to the septum. I will show you. Give me 40 blade. I will take from the above side because I will be needing frogens for the margins. My diagnosis is already established. See, such a vascular tumor.
Yeah.
And this was the tumor going through the septum. See that? Eroded the septal flap on this side. See the cartilage. See that?
Yes.
See that? See the septal cartilage there.
Yeah.
This is what we could establish. What I was trying to see here, whether the opposite flap is involved or not. If the cartilage is breached, you can't take the opposite flap in that
Yes.
region. This is why I am not elevating the flap before I ensure this. Got my point?
Yeah.
I want to see whether the opposite side nasoseptal flap is involved in this upper part or not. See this? Sometimes you have to be aggressive in surgery, you know, like this. See, this septum is pushed. Can you see?
Yeah.
Hello?
Yes, yes. We can
Yes,
see
sir.
that.
It
Yes.
is pushing the septum,
Yeah.
not transgressing the septal cartilage. See that?
Yeah.
In such situation, one can think of harvesting the upper part as well.
Yeah.
See, it is a predominantly right-sided tumor. Okay? See now, after this debulking, everything will be much clearer. So this step I want to do as fast as possible. Because this will open up the space. This will allow us to see our landmarks much better. See, I am going fast, very fast on this luminal component. See your landmarks, the terminates. See the coina behind.
Yeah.
Give me the through cut. I hope you are oriented.
Yes, yes.
Yes, sir.
So you can expedite your procedure sometime by doing certain maneuvers, you know.
Yeah.
See this part of the tumor.
Yeah.
उसी में रख लेना बायोप्सी के साथ. भेजना नहीं है बाद में. Not for frozen. Wash. See now. Wash. Now you see your septum much better. What this tumor had done to the septum? See this?
Yes.
It had eroded the septum on this side, eroded the mucoperiosteum completely, pushed the septal cartilage or the septal bone to the opposite side, but not transgress to the opposite mucoperichondrium, periosteum. Can you see very clear? So what I have done, I have developed the space. Got my point?
Yeah.
And this is useful section. Because after this now I am going to go to the opposite side and harvest my flap first.
So also I want everyone to see how he's taking care of the orbit. You know, how he's managing the orbit, knowing that it has gone towards the orbit.
Yeah, I will show you once I go to the orbital plane.
Exactly. So he's taking a lot of care. You saw all the debridement was mostly central base. He's left a small bit of tumor near the orbit, and he showed part as well.
Now I will just put a adrenaline shock pack here. Narayan, before coming to this side, my concern first is to harvest the flap.
Correct.
If you want to see the orbital part, I can show it here in 2 minutes.
No, Satish, I just wanted to throw light on it.
Because even that is not going to affect my flap part, what I am trying to show.
Exactly.
Okay, let's see.
Satish, the reason why I was throwing light on it is because some junior person in deciding this whole thing will go through the vital contents. So that's why I was throwing light on it.
Absolutely, Narayan. And Narayan, you know, looking at the CT scan and MRI, you know, anybody can think of, anybody can assume the orbital involvement and think of orbital excentation. It looks so massive.
Yes.
But truly, if you look at the MRI carefully, the layers of the orbital wall, I will show you now. See now carefully.
Yes.
It is not invading, it is pushing. That's what I want to show you now. You will find most likely the periorbita intact.
The whole management is changed by this sequence. Knowing the sequence can completely
MRI is game changing, boss.
Yes.
So I think I always admire the way Satish reads his MRIs. I think if every surgeon could start reading the MRIs as effectively, life would get better for a lot of people.
Sir, many radiologists are following our webinars just to know the final details of the imaging.
That's a part of the middle tabinate involved by the tumor. See, this part of debulking, keep irrigation, expect little bit of the bleeding, but expedite it so as to minimize the overall bleeding. Faster you go, overall bleeding will be less. There's no point in wasting time into it slowly. That will lead to more bleeding. See, everything is compressing onto the orbit.
Yes, sir.
That is what I want to uncover. बंद हो गया. Give me open up the blade. The part of the uncinate. That is part of the uncinate to open up the maxillary sinus. See this maxillary sinus?
Yes, sir.
Yeah.
Yes.
Yeah, yeah.
Reverse biting, reverse biting. And this will give me a good plane to enter into the lamina papyracea plane. Wide middle metal enterostomy. We know from the MRI there was nothing but just mucosal edema, see na, secretions, nothing else.
Yes, sir.
We knew it from MRI.
So Dr. Poonam has a question from the previous surgery, that which is the best place to take the fat? Abdomen, thigh, any particular preference of taking the fat?
What is the best
place to take the fat? Maybe for the previous surgery, she wants to know for CSF repair, the best place to take the fat.
Thigh.
Thigh.
We prefer thigh because the fat from the thigh is more knitted than the fat from the abdomen.
Yes.
Okay.
What the bana? Eye ko. See now, I have asked to press the eye from outside. See this. To get into the plane.
Yeah, so what you can see is he's trying to dissect off and find the periorbita. Right, Satish?
Yes, that is what I am trying to show you.
Exactly.
The lamina is gone, we know it.
Yes.
Periorbita is the most, resistant structures for the tumor invasion.
This is the periorbital fat which we are seeing?
No.
What is that white thing, yeah?
No. Tumor. See,
Okay, that's
I will
tumor
tell
mass.
you. This is compressing, see this?
Yeah.
My periorbita is there behind, see now.
He's expecting the periorbita to be normal.
See that?
Yeah.
See that?
Yes. Totally intact.
Yeah, absolutely intact. I will show you. I will show you exactly the plane.
Yeah. Because at this level, one has to be very careful,
Yeah. See, this is periorbita. See, this is normal periorbita.
Yes.
And this bone I will take.
Yeah.
I will. Section upar. Yeah. This bone. Section. This bone I will pull medially to get into the periorbita.
This is part of lamina papyracea?
Yeah, part of lamina papyracea, partly eroded.
Yeah, that is what.
That's why it is pressed laterally. It's a thin bone.
Yeah.
Once the continuity is lost, it gets pressed.
Yeah.
This olfactory neuroblastoma, by and large, is orbital sparing tumor.
Yeah.
Though we have seen many of the cases, advanced cases, with bilateral orbital involvement. Invasion.
Yes.
That is one where it is, you can consider.
Say, in your experience,
you can't think of bilateral orbital exentration in any patient. That is too traumatic.
So how the patient presents, with the nasal obstruction or anosmia in these cases?
Yeah, they present with anosmia, nasal obstruction. See now, that is the area of the frontal recess.
Yes, sir, yes.
This is the lamina papyracea.
Yeah.
Lamina. This is partially eroded lamina papyracea. That is your skull base behind. And this is the tumor which I have, taken from anteriorly.
Yes.
This is taken from superiorly. See this?
Yeah.
See, this is the part of the tumor.
Yeah.
Yeah.
So the septum. So, see, this is the site of
Wide
attachment
margin
of
on
the
the
tumor.
septum.
Can you see? This is the
Satish?
site of attachment of the tumor.
Yeah.
This is the skull base.
Yeah.
Yeah. That is the site of attachment of the tumor. See that behind?
Yeah.
What point?
So what will you send for frozen? Like which part?
Pardon?
So for frozen section, which part will you send?
Dural. See, this is the dura behind.
Okay.
Yeah.
Okay.
Once I remove the skull base, I will take the flow. See the anterothoidal artery?
Yes, sir.
Yes.
Give me the coagulator. Because this part of the skull base was eroded. Anyway,
Yeah.
we had to coagulate this vessel in the planned way. Gone?
Uddhav, the purpose of frozen is to find out that we have not left the tumor mass inside.
Yes.
We have to see the margins.
Yes, absolutely. In malignancy, the most important thing
Yes.
once you perform surgery is to have a clear margin.
Yes. And the best way is to do is the frozen, because you can take another chip of it right now.
If you are through the tumor,
Yes.
you can go beyond and take a
Yeah,
tumor
yeah.
margin. Okay?
Yes.
Now see what I have done so fast. It was pure debulking.
Yes.
Until now, going around the tumor, what I have done is debulking. See this.
Yes.
This is my lamina. This one.
Yeah.
This is the frontal recess. The dura is behind. The tumor is attached here. In
Yes.
the midline onto the skull base.
Yes.
sir.
This is all tumor. You can see the anatomy much better now.
Mm-hmm.
And this is all tumor. See, I did all this quickly. See, this is all tumor.
Yes.
Now, I know the tumor is not going into the sphenoid.
Yes.
How do I know? MRI.
Yes.
So now, give me a pack here. So I will clear it from the sphenoid and show you, like anterior limit, you can see the frontal recess.
Yeah.
Not involved. See
Yes.
this anteriorly? Not involved at all.
Yeah.
Now I see this anteriorly not involved at all.
Yeah.
Similarly, I will show posteriorly where it is not involving, and then in between we will remove the skull base.
Remove the tumor.
So just pack for a while above to improve the field. A little bit of the oozing, nothing else.
Yeah.
For such tumors, to me, it is a very good field.
Yeah, there is not much of oozing as we expected.
There is hardly any.
Yeah.
That's because Satish Jain is operating in
People
very
can take hours and hours for the same thing.
Yeah, to reach to that
Believe
stage.
me, ultimately, if your surgical time is prolonged, your overall bleeding will be more. So sometimes you have to be very, very effective, you know. वो इधर हम हिंदी में बोलते हैं कि बीच बीच में राक्षस बनना पड़ता है. Today is Ravan.
Yes, sir.
Now, where is the sphenoid? Let me show you. This is my coina.
Yes, sir.
See, this is all intact below.
Yeah.
It never takes attachment here. Now, give me the debrider straight. See, the field is so good.
Very good.
Yes.
Now, this is my Sphenoid sinus.
Sphenoid.
I'm widening the. See, inside the sphenoid is very clear.
Yeah.
Block हो रहा है. And we saw on MRI the sphenoid was not involved by the tumor.
Yes.
See from inside, it's crystal clear.
Yeah.
Some secretion which were out. Otherwise, rest of the things are okay. I have not raised my flap yet.
Yes. Dr. Satish, though the sphenoid has shown to be clear, will we like to take a part of mucosa for frozen to be doubly sure?
From
Sphenoid?
Not really. It is so clear. Why?
Okay.
Where is the doubt? See this.
No, there is no doubt about to be doubly sure if you want a frozen, since the frozen facility is there.
See, once you want to be sure, you have to have a reason behind it. We have a
Okay.
backup of the MRI showing everything clear.
Right. Okay, fine.
So just, and you can confirm endoscopically,
Yes.
mucosa is absolutely normal inside. Wash.
Yeah, so unnecessary. Why to sacrifice the mucosa for taking
It is
it?
mucosa, absolutely
Yeah, yeah.
normal.
Yeah, yeah.
See
Yes.
what is there? What is decent? See the pulsations.
Yes, yes,
Carotid.
yes. Yeah, yeah.
Just decent.
Yeah.
Carotid is decent in certain percent of normal individuals, you know.
Yes.
Be careful not to do any sharp instrumentation.
Yeah.
A situation blindly
Yes.
can lead to a disaster otherwise. Now, the brighter. Yeah. See this part of the lamina which I'm removing.
Yeah.
See this.
Yes.
Yes, sir. Yes, sir.
See the plane with the lamina papyracea and the periorbita.
Yes.
Can you see?
Yes,
Yes,
sir.
yes,
Very,
very
clear. Very clear.
Now see the periorbita, quite clear.
Yes.
It was earlier compressed, now it is bulging.
Yes.
Now, I have to ensure on both sides where the tumor was gone to the limits, to the boundaries, but not invading. I have to confirm. This is the lamina side, absolutely normal, you know. On whatever lamina, it is projecting, you know, it is bulging the periorbita. See this? Hello?
Yes, yes.
Normal periorbita. Narayan.
Yes, yes, I can see it.
You were asking about the orbital invasion. See,
Yeah.
periorbita is the most important barrier.
Yeah.
See, it was compressed, not involved. See that?
Yeah,
And
yeah.
whatever it is bulging, I can immediately control by means of coblation.
So, Satish, after removal of this tumor, would you also consider this an R0 resection or was it an R1 resection?
Yeah, R0 was. See, in cancer, there is one principle. By and large, applying everywhere. If you plan to remove a cancer, leaving a little bit behind, taking care of that with the radiotherapy is a joke. It is a complete resection which can take you to the cure. You know, leaving a bit of tumor behind, thinking that you would control with the chemo, radiation, whatever, cannot work. That can never be a goal. See this? I pushed the periorbita back, which was bulging.
Yes.
I hope everyone is clear about the orbital involvement now. It is free.
Yeah.
See, so much of the orbit or was compressed, you know.
Yes, yes.
What I told you from MRI, it is not involved. This I have seen in hundreds of these cases. We have a huge series of olfactory neuroblastomas. These are very, very favorable tumors, believe me. Those who are watching, those who are doing endoscopic surgery, believe me, this is one of the most favorable tumor any endoscopic surgeon can do. This is my goal today to demonstrate you can do it. Get a good MRI, good understanding, good planning. Decision making is important.
Yes.
My orbit is absolutely free now. Now we'll deal with the skull base. See my below the maxillary sinus. See the nasal cavity part, maxillary sinus part all removed.
Yeah.
See the sphenoid part all clear.
Yes.
This is the septal part which was pressing on the septum which we removed. Though I'm going to sacrifice this part of the septum. And
Yes.
this is part of the tumor. See this dura below. See this dura where the tumor is involved.
Yeah. So till now we have you have removed all around the tumor and
Yes.
getting control of it. Okay.
Yeah, that's what I said. My goal is to truncate the tumor.
Truncate the
point
tumor.
of attachment.
Yes.
That is my goal. And see, this is anterethmoidal artery here
Mm-hmm.
in my instrument. See this artery?
Yes, yes.
And this is something I will take into control to devascularize the tumor.
Yeah.
This is the added advantage of this approach over the transcranial one, where you can devascularize the tumor, which otherwise from transcranial side is across the tumor. Now, those who have a fear, see this is anterethmoidal coming out of the orbit. Those who have fear that if the orbital periorbita is breached, I mean injured with your instrument, if your fat is exposed, you can cobble it. I have shown a couple of times. See this? Now it is completely away from the skull base. Can you see?
Yeah.
The orbit is segregated. See this?
Yes, sir.
Yeah.
I hope the picture is good.
Very, very good.
See what a tool cobblator is.
Yeah.
Sir, Dr. Nagia wants to know what is your follow-up modality of imaging in these cases to follow up the patient.
MRI.
Okay.
See, CT has limited role of giving bony details. That's it. CT cannot give such sequences to characterize the soft tissues.
Yes,
What will
sir.
you get from CT scan?
And sir, what will be your timing of scans for the follow-up?
Timing of scan, depending upon the resection, first of all. See, these all you have to define yourself, the kind of resection you have done. If you are confident of giving R0 resection, no point in getting early scan. You can see now my orbit is separated here.
Yes, sir.
Completely.
Yes.
Yes.
Now below, this is what the posterior artery.
Yes.
See here.
Yes. Yes.
Very clear?
Very clear.
Yeah, yeah.
What I will do to it? The same thing.
Same thing. Cauterize it. Ablate.
To devascularize the tumor. First coagulate.
Then ablate.
Those who have a fear of ethmoidal arteries, they can see in different situations how you can easily deal with it.
In your hand, it looks so simple, but once
anybody
we
can
go
do
ahead, it always look very tricky, you know. So you
Anybody
make
can do
it so
Jerry.
simple.
No, believe me, everybody can do it. It is so heartening to know every day I get to know from somebody who has done angiofibroma for the first time after the webinars.
Yeah.
I feel so good. This is the aim.
Yes.
You can do this surgery. Believe me, if I can do, you can do. As simple as that.
Only thing is a proper learning and don't jump into it. I always say there is a graduation. You graduated technique. So
yeah.
And so also the right quality of tools. The tools, every equipment is important.
Equipment is important, but full behind the tool is more important. Proper training, patience, gradual learning, watch the people doing, talk to them if you have any doubt, and that is the way we learn.
Yes, sir. Yes, sir. Very good.
Right. See, now I have cut off the vessel.
Yeah.
Completely separated. This is my skull base. Can you see this?
Yes, sir. Yes.
This is my skull base, which I am going to drill.
Yeah.
To reach the normal dura around.
Yes, sir.
Yeah.
I will show you once I enter the cranial cavity. So what I have done, see, I have separated the tumor, remove the luminal part,
Yeah.
exposed all the sinuses. This is maxillary, very clear.
Yes.
Sphenoid and the frontal above.
Frontal.
Okay?
Yeah.
Beyond the tumor, everywhere. Now what I'm going to do is, my area of interest is this one. Okay? Okay, give me the drill first to just clean some areas, some bones. He's so clear. I hope you are oriented.
Yes, very well.
So bleeding has stopped completely from all over.
Cobblator, man. If you have a cobblator, you have so much.
It is the experience, tissue handling, then the cobblator, boss, not the cobblator alone.
Yes, sir. Yes.
The tool is important, sir.
Tool is important, but the fool behind tool is more important. It is the experience, perseverance, persistence that makes you perfect,
कम करना पानी.
Just tool पकड़ा देने से बंदर के हाथ में उस्तुरा हो जाएगा बॉस.
See, this is my stylus drill.
Yes, sir.
This is now man of the match here.
Yes, curved one.
So that's 15-degree curved.
Yeah.
I can go all around. See, with this curvature.
Yes, sir. Wonderful.
So you can have drilling under direct vision. That is the biggest advantage.
Yeah, 40 there. See, everything clear. No trace of tumor.
Yeah.
The area we have passed through.
Mm-hmm.
Nothing.
So for adenoma cases also you use the same stylus drill for pituitary adenomas?
Yes, same.
Okay.
For all skull base work. See, under vision, everywhere we have removed the tumor.
Wonderful picture, sir.
You can go close up. This is the remnant of the lamina, which is not involved. I am removing under vision.
Dr. Satish Ji, just a thing came to my mind, like you are getting so many revision cases operated by so many surgeons, and where mostly we don't get the details of surgery. So can't we train after each webinar, like how to write a OT note? What are the steps taken? What are the structures were taken off or what are left behind? Will it not be a good idea, sir?
Yes, sir. It's always a good idea.
Yeah.
Should be like this.
Yeah. Because right now in this case, we have seen what you have done. We started from the lumen, then we went to the different sinuses. So those things must be mentioned in the OT note,
yes,
which is to be shared with the discharge ticket.
Yes, sir. See now, just to show you everything clear.
Yeah.
This is orbit.
Yes, sir.
Maxillary. This is maxillary sinus. Sphenoid.
Yeah.
That is the sphenoid sinus, and that is the skull base exposed.
Yeah.
Beautiful, sir. Wonderful picture.
Now my next goal is to go to the skull base. Now this is a unilateral lesion,
Yeah.
Yes.
We saw from the scan, see, the tumor was pushing the septum. See?
Yes,
Yeah.
sir. Yes.
Opposite side paranasal sinuses were crystal clear.
Yeah.
They have to be removed as a part of procedure when the entire skull base is removed. You know?
Yes.
If I happen to remove, I can do this in 5 minutes, this entire frontal thrombectomy, whenever required.
Now, are you going to raise the flap?
Later.
Later, okay.
Yeah. Now, this is my area where the tumor is going. See that?
Yes, sir. Yes.
That is the skull base part. That in the middle is the cribriform plate. See that?
Yes, sir.
This is from where the tumor is going intracranial, inside. So I have to define this area completely with free margins. So that is the most important part as far as the outcome is concerned, that to have a free margin. Okay?
Yes, sir.
Now the question is, do I need to go to the opposite side for the dura? See, now I am double-minded. I can go around the dura from here only. Anyway, I have to raise the nasoseptal flap from the opposite side.
Yes.
And
that's why I asked about the
I
flap.
should not miss anything. So
Yeah.
let me do a complete frontal thrombectomy. Anyway, I have to remove this part of the septum. See, this part of the septum.
Yes.
Which was involved by the tumor here.
Yeah.
Yes. So the dura part has already crossed the midline.
Yeah.
I should not compromise with the exposure. I am not raising the flap still.
Yeah.
I'll be a little extra careful not to damage.
Mm-hmm.
See now what I'm doing. Since this part of the septum is involved, this is the, the turbinate, middle turbinate. Yes, I showed that attachment. Now, once I remove this part of the septum and the ethmoids on this side, everything will be clear to you through and through on both sides.
Yeah.
To orient, give me debrider. Debrider. See, this lower part of the septum is free.
Yeah. Only the upper part is.
Yeah, this we knew from MRI.
Yes.
Yes, sir.
See this involved part of the septum. I am removing. See that?
Yes, sir.
Yeah.
Yes.
This is normal portion now I have reached, but still I am taking it so that I don't take a chance. So now quickly, I will finish the ethmoidectomy on this side.
Yes.
See the lamina, and then see the lamina on the opposite side through the septal window.
Yeah.
Yes, sir.
And from here, I will come to the lamina on this side. Now I have not raised the flaps. I have to be careful not to damage the vessel while doing anything further. Okay? That's why the standard teaching is to elevate the head before, but with less exposure, it makes your life difficult,
Yes, sir.
So you postponed putting the flap, taking the flap, number one, because of a better vision, and to check the vascularity of the flap you will be taking out. Is that so?
No, the vascularity I should not take out.
Okay.
Accidentally.
Yeah.
Accidentally. Why we raise the flap first? So that you protect the vessel.
Yes.
Now see the maxillary sinus.
Yeah.
Now this side of the frontoethmoidectomy I will finish quickly in 5-10 minutes.
Yeah.
See the secretions in the maxillary sinus.
Yes. Yes.
Nothing else. That we knew from MRI.
Our MRI.
That is the lamina papyracea of this side.
Yeah.
See this. See this.
Yes.
See the lamina?
Yes. Yes. Quite healthy.
I am removing toto. It is all this mucosa.
Yeah.
With this now I'll have a full bilateral exposure because I should not compromise here for the skull base part. If I compromise with the exposure, I may compromise with the skull base clearance. Suction. So in next couple of minutes, I'll be completely through with the exposure and then we'll go to the skull base. Right? Fat glue. बोल दो. Most careful part here is the sphenoid because I should not damage the pedicle. You know, one of the things which is counterproductive in Hadad flap, you know, it has to be raised before the resection. Got my point?
Yes, sir. Yes.
Sometimes you never know how big a flap is required. It may fall short.
Yes.
Or sometimes you raise a much bigger flap than required. Here, by not elevating the Hadad, this is the small advantage which I am going to have today.
Okay.
See now, the orientation. The maxillary on this side.
Yes, sir.
Maxillary on this side. Okay. Nasal cavity this side.
Yeah.
Nasal cavity that side. Look now. Okay. Sphenoid this side. The opposite sphenoid. Now
Yes.
my sphenoid is here and here. Why I am saying so? I should not damage the pedicle because the pedicle is immediately caudal to the ostium.
Yes.
So I have to stay little cautious. See the sphenoid on this side? See the sphenoid?
Yes, sir.
Now the ethmoidal roof on this side completely. See that? Now I will take 70. ऊपर से मंगाया 70. ये टूट गया, गिर गया इसका. इसका गिर गया क्या? वो गिर गया इसका पेज. Now getting the picture with the 70. Hello.
Yes, please orient. Yeah.
Yeah, we are getting a picture, Satish.
Yeah. See now, To orient you with a 70, this is the maxillary on this side.
Yes.
Some secretions, see this?
Yeah.
This is the lamina on this side.
Yes.
This is the skull base. This is the lamina on the opposite side.
Yes. Very clear.
This is the sphenoid opposite side. This is the sphenoid on this side.
This side, yeah.
This is the skull base on this side. That is the skull base on that side.
Yeah, very
Here
correct.
it is the involved skull base.
Yes.
Now, that is the frontal recess of the opposite side. See that?
Yeah.
Okay? And this is what I have to clear on this side.
Yes.
The brighter. See the frontal recess on this side?
Yes.
This is the frontal recess of the opposite side. This is the frontal recess of this side.
Yeah.
Both you can see.
Yeah.
See that? On both sides you can see.
Yes.
In between is what?
That is the tumor.
Cribriform, tumor.
Yes.
This
Yeah.
one. This
Yeah.
is more toward the right side. See that?
Yeah.
Now
Yes.
my goal is, as I said in the beginning, from frontal to the sphenoid. This is sphenoid
Yeah.
and anteriorly frontal. This one, frontal to the sphenoid and orbit to the orbit. This entire skull base around the tumor, along with the margin of the dura, I have to remove.
Yes.
What's my point?
Yeah.
And in order to do that, I needed this much of exposure. See, how would I do without this exposure? How would I do?
Possible.
So now my work is with a 70 degree.
Yeah.
Wash. I have not raised the hadad left below. I will raise according to the need. Okay?
Yeah.
क्या हुआ? See this.
Yeah, you have a nice clean exposure and margins.
Pardon?
You have a good exposure and good margins, I can see.
You're happy, Narayan?
Yeah, of course, Satish.
The brighter, 40. Now my area of interest is in my view, all the way in my view. What I need to remove, how beyond everything is in my view. This is the area which I want to remove intact. See, all around?
Yeah. Can you imagine before endoscopic era how people used to do it?
How people used to do it? Transcranial.
Yeah, before endoscopic era, say 10 years back, how these tumors were taken care of?
Transcranial.
Yeah.
And the disadvantages are numerous, I tell you.
Yeah.
Obviously, the intracranial component, you can remove transcranial efficiently.
Yeah.
But this kind of intranasal extensions, how can you do without endoscopy?
Yes. So was it a reason, if you think retrospective, pre-endoscopic era, the chances of recurrence on the mortality were so high?
Yes. And irrespectively, patients were subjected to radiation. Still,
Yes.
a lot of people who do not know this, they're subject to radiation. As simple as that. I should not name.
Yeah.
I think there was a lot of mortality also, sir, because a lot of brain retraction. I have had
not only brain retraction, oozing is a big issue.
Bleeding, yeah.
Obviously, the intracranial part can be removed efficiently by that. But how would the intranasal part?
Yes. And to come from intracranial to nasal part from the above down is very difficult. Basically,
we can remove, but
yeah.
this kind of illumination, exposure, margins,
Yes.
what you see with the endoscope cannot be.
Yeah.
Can't imagine.
Mm-hmm.
No one can think of. Now let me go all around the tumor. Okay.
Yes.
First give me cobblator and then drill. And all around I will go through the normal dura around the tumor. See now the picture.
Yes.
Now cobblator first. See the skull base is exposed. This side, ethmoidal arteries I have not taken yet.
Yes.
Opposite side I have taken.
Yeah.
I have to define my anterior limit also.
Yeah.
See the dural, you see the intracranial, you see the dura which is pushed.
Yes.
The bone is already gone there. See that?
Yeah.
I can push, I can see the margins, bony margins.
Yes,
So now
sir.
I will
Yes.
enter into the tumor. I will start removing, going around the tumor from the healthy side. That's the basic principle. Drill.
Yeah.
पानी कम रखना, ऊपर से डाल देना. See now, this is the healthy side. What?
Yes. Yes.
This is the healthy side. This is lamina.
Yeah.
वो section में रखो. See, I am drilling the ethmoidal skull base.
Yeah.
पानी डाल. ऊपर नहीं, ऊपर से डालना ऊपर. हाँ. Yes.
Sir, isn't the four-handed technique easier with the 0-degree scope than with the 70-degree scope?
I keep changing with the assistant, you know.
Okay.
See, I am drilling the skull base beyond the tumor. Can you see? This is the region of my ethmoidal artery. See, this is limiting my drill to go up. See the region of the ethmoidal artery?
Yes, yes. See? Yes. Very clear.
Ethmoidal artery. Get the cobblator there.
Yes, sir.
Yeah, that was the ethmoidal artery, which we have to coblate, both anterior and posterior. Now, see the skull base has been out. Drill.
Yes.
See, I am going to remove this skull base over here around the tumor. Similarly, my posterior limit is what? Posterior ethmoidal artery. See, my posterior limit here is just anterior to the sphenoid sinus.
Yes, sir.
See the sphenoid sinus there behind?
Yes.
Yes.
Posterior limit of transcribiform approach is the postsigmoidal artery. Anterior limit of transplanum approach is postsigmoidal artery. So this is a very important drilling. I can see the skull base mobilizing. See the complete skull base?
Yeah, we can see that.
Mobilizing. This is my posterior limit. I will show you the dura, the normal dura, once I drill away this skull base. Because I have to go around the tumor to enter intracranially through the normal dura.
Yes, sir. So Dr. Fazali wants to know, like in this case, will you give radiation post-op?
100%.
Okay.
This is advanced, going intracranially. See this, around the tumor, okay?
Yes, sir.
See your sphenoid sinus on both sides behind. Okay? And this is the skull base. See, I drilled away, I made it mobile. See that? See, it has become mobile.
Yeah.
Thinned out the bone.
Yes, sir. Yes, sir. Beautiful.
There, drill there. इसको इधर से डालना है. So all around, I have to drill, then finally flack out this bone to uncover the normal dura. Okay?
Yeah.
This is my anterior limit. This is behind the frontal sinus. See that bone?
Yes.
Yeah.
This is my anterior limit of resection, which I am defining.
Yes.
Now, oblator. And now I'll go to the opposite side, the opposite lateral limit. Okay?
Yeah. So here we mobilize the dura and with the tumor on it.
So what I will do, sir, why I mobilize?
Yeah.
This dura underneath. See, this is a normal bone.
Yes.
If I remove this bone now, this dura underneath is a normal dura.
Yeah.
I need a normal dura all around at the margin.
Yes.
See this?
Yes.
See the normal dura?
Yeah, yeah.
See the thin bone I left behind?
Yeah.
After drilling, and see the normal dura as a margin.
Yes.
I will make my intracranial entry through the normal dura.
Yes.
See the dura in the midline which is involved. forceps. And see dura laterally, which is not involved. Can you see very clear?
Yeah, it's so clear.
Drill. So this normal dura I want all around. इसको थोड़ा यूं दबा.
Yeah.
Go there. Carry some. See the involved dura in the middle. और ये क्या दिया है?
Yeah.
For the articulated. Above is the anterethmoidal artery. I have not yet coagulated properly.
Mm-hmm.
See, that is the artery.
Yeah.
Below that is the bone piece which I have removed. Now I will coagulate this vessel. No bone there.
Yes.
Drill there. See the normal dura. One there. Drill there. Drill. See all around. Keep an eye on the midline. This is involved dura. And this is normal dura.
Yeah.
How much I can remove until I am satisfied that I am beyond the disease. So, stop later. See, this is where the anterethmoidal artery was going. Here. Done? Articulated. Section there. See, this is the area where you have to give some time, you know. See the normal dura?
Yeah.
Absolutely normal. See the pulsations. And see in the midline the kind of dura is. So I have to go all around this normal portion of the dura. The goal is to remove this dura with wide margin. See this? This is all normal dura. I hope you are oriented.
Yes, sir. Very well.
Step right up there. Putty. See on this side the complete margin of the normal dura.
Yes, sir.
Yes.
I have to define it all around.
Yeah.
Now coming to the opposite side now.
Yeah.
on this side, you know. You have to push this. No. Push this. Periosteum. ये ले ले वो section periosteum ले ले. Section periosteum. Take section periosteum. This is a very important part of the surgery where you have to go around the tumor. This tumor is transgressing the dura. The dura is involved and you have to go around the tumor to go through the normal dura. 360 degree.
Yes.
Drill. Press this. See now the orbit which is bulging and see the bone.
Yeah.
Side kare iska chhed. Yes. See now?
Yeah.
Now I will daba ke rakh. See the thick skull base.
Yeah.
Sir, Professor Majumdar is watching your dissection. He asked me to convey his regards for the excellent dissection.
Convey my regards to him. He is like our grand teacher, boss.
Yes, sir. He told there is some Professor Narayanan in Rajasthan who used to do an open CFR very well in his era.
Yeah, no, he is such a senior person, 87 years old. So keenly watching all the webinars and commenting is commendable. See what I am doing, the same thing what I did on the other side.
Yeah.
To discover the margin of the
Normal dura.
normal dura beyond the tumor which is there in the midline.
Yeah.
See the normal dura below.
Yeah.
See what a drill it is. Because of this angulation, inherent curvature
Beautiful, sir.
can be used for anywhere.
Yes, sir. Wonderful.
This is an amazing product from Medtronic. Silas. देना यार डालना नहीं दिखे तो डाला करना सोचता क्या ऐसे दिखना चाहिए चलो सेक्शन करो see I am going around completing the drilling all around and then discover the dura and then I will open the dura.
Satish?
Yeah.
With your permission, can I take your leave today?
Of course, Narayan. Thank you.
Yeah. Thank you very much. It's been very nice. As usual, very informative.
Thank you, Narayan, sir.
Thank you, everyone.
Thanks a lot, Narayan, sir.
Thank you. Thank you.
Thank you,
Satish, great
sir.
job as usual. Thank you. Satish, great job as usual. Great job as usual, I think.
Thank you, man.
A lot of information and good stuff.
See, like opposite side इसको press कर. करना, press कर. Press. क्या है? See, once your periorbita is exposed, you have to keep it away all the time, you know. See the normal dura?
Yes, sir. Yes, sir. Very clear.
Gobleter. Section कम खाली section नहीं चाहिए हमें बेटा. See, pushing the periorbita. This is very safe with the cobbleter, you know. Doesn't damage anything. क्या बंद है section. कब See, removing this bone to get a good dural margin. That is the entire goal all around. I hope you are getting what I'm trying to say. See the dural margin? This is normal dura, you can say.
Yeah.
And once I discover all around, I will make the opening into the dura to go inside. Now anteriorly. Give me the carry articulated. See anteriorly, still not defined. Rest three sides I have defined. You can see. Wash. Hello?
Yes, sir.
Yes, sir.
Just to keep orienting. See behind. Section karna. See behind the normal dura. See on this side the normal dura.
Yes.
Yes, sir. Sir, the question is there. They're asking, is there any effect of coagulation on periorbita?
Effect of coagulation?
On periorbita. Long-term effect.
No. It's very
Yeah,
safe.
that's what it is. Yes.
I have been doing it regularly. And see,
On
the
brain also.
coagulator is always with the irrigation, you know.
Yes, sir.
That doesn't allow the collateral thermal damage.
Yes, sir.
That's the beauty. See, I'm in the midline.
Yes, sir.
Anteriorly. And what I see here, what I'm removing, anybody, what is this? What bone I am removing? That is the crista.
Crista galli.
Crista galli.
Part of the front.
That is the crista galli. See now?
Yes, sir.
Yes.
See where the crista galli was going. So crista galli is an extradural structure. It's a part of the perpendicular plate of the ethmoidal bone going up. But staying extradural. See that?
Yes, sir.
Yes, sir.
Now see the anterior dura, very nice. Everywhere, all around, to me the dura is good. See that?
Yes.
తెచ్చినా అన్ని అదే మొత్తం అయితే కొన్నావు ఇంటర్సెప్టర్ మొత్తం అయితే కొన్నావు అంటున్నా బాగుందా అదే
See the extra bone I am removing. This is my
Yes, sir.
articulated bunch. This instrument I was using was articulated punch. Absolutely fantastic. Now, good margins. See the dural surface, the normal dural surface you can see very clear.
Yes, sir.
Yes, sir.
Dura in the midline above, what is there up is the fox cerebri, where the superior sagittal sinus starts. Okay, so now, by and large, this is what I was saying, truncating. See, what we have done so far, debulking, exposure, and reaching to the area of invasion of the tumor. See, all around is all normal.
Yes, sir.
This is the area of interest. See that? This is
Yes.
the tumor where it is going intracranial. See the normal
Yes,
dura
sir.
all around.
Yes, sir.
And now is the timing of my dural entry knife. Oh, up and scissors. See that? Panoramic view. I hope you are oriented.
Yes, yes,
Yes.
yes. We are, we are.
Nice. Now, first to enter into the dura from the normal side. Okay? Can you see this dural knife?
Yes, sir.
Yes.
Up front. Not through and through. So पकड़ थोड़ा. ये पकड़. थोड़ा सा. लो. शार्प नहीं है यार. पकड़. पकड़. Now see, we are in. Hello.
Yes,
Yes,
yes, yes,
sir.
sir.
Yeah. Pull कर, pull कर. यहाँ से पकड़ यहाँ से. कर नहीं है यार. और अप कर दे इससे ऊंची वाले. Your other scissors. Scissors is not going there. That is the basifrontal lobe. Can you see?
Yes, sir.
Give me a marrow cell, small marrow cell. I am just pushing a small piece of marrow cell inside to protect the brain. Okay? I don't think. See this? Pushing this marrow cell in to protect the neurovascular structures.
Yes, sir.
Wherever I am going. See this? So give me the cobbleter. Fox could be here. I'm cobbleting. Utha. Yes. See, this is a help from my assistant. This is the region of the fox.
You're cutting the fox, right, sir?
Yeah, I'm cobbleting first. See this?
Yes. Very clear.
First cobblate and then cut. See, advancing marrow cell inside to protect. Can you see?
Yes, sir.
Yes, sir. Yes.
Don't worry. Oh, now I can show you the internal structure. Let's see first. Can you see? Hello?
Yes, sir, we can see.
What is this? Olfactory bulb.
Olfactory bulb, yeah.
This is olfactory
Right.
bulb.
Bulb, okay.
Give me the, yeah. So just now I will cut from behind. Section. Cobbleter.
Sir, Dr. Fazali wants to know, is there any chance for herniation in future, brain herniation from this large defect?
Not really. That can happen if there is a situation of high intracranial pressure or something like that. Surgical. Otherwise, doesn't.
Okay.
See, we entered through the normal side so that we can see the margins beyond.
Yes, sir.
After
Mm. Yeah, we'll see later. Now, section. We'll cut all around the tumor, okay? कोई बात नहीं सीधे था दिख रहा है डालूंगा ये see through the normal dura
Yes.
wait खींचो मत
Now that's other side olfactory bulb is clearly seen.
yes see the tumor along with the dura इसको पकड़ yes यहाँ से पकड़ना पास से यहाँ से पकड़ना see this
Yes, sir.
you have to ensure that you are cutting through the normal dura which we discovered underneath the bone remember can you see now very clear
Very clear, perfect.
हाँ छोड़ दे इधर से पकड़ see this part of the tumor which is going in see now keep an eye
Is there some pile invasion there, sir?
pardon
Is there some pile invasion at that region where the tumor is going in?
no not at all okay छोड़ दे now see see this part of the dural attachment
Yes.
wait you can see the fox you see the fox
Yes, sir.
Yes, sir. Yes.
This should be thoroughly coagulated to prevent the venous bleeding. This is very important to prevent unnecessary bleeding. Hold it, hold it, hold it. पकड़ना. Could you see?
Yes, sir, that's a beautiful dissection. Fantastic, fantastic.
And what I want to see now is the status of the olfactory tract. See the olfactory tracts going behind.
Yes, yes, we can see at the level of planum, near the planum.
No pile invasion. See that?
Yes, yes, yes.
It came out with the dura. Entire arachnoid is maintained. See the plane.
Yes, sir.
See all around.
Beautiful, sir. Yes, sir. Wonderful.
Track cut. Bulb. What I'm looking at is the olfactory tract, you know. What a great arachnoid plane maintained. See this?
Yes, yes.
See, this is for the sake of, you know, I will send it for separate histopathology. You know? Hello?
Yes, sir. Yes, sir.
This olfactory.
Yes, sir.
Separate right. It is not uncommon to see the involvement of the olfactory bulb. Or sometimes even if it is not involved, cleared for the sake of a margin.
Sir, if it is involved, what is the next plan? You are going to resect the head, or are you going to continue the radiation?
Pardon?
If the olfactory bulb and tracts are involved, what is the next plan? Are you going to resect further, or are you going to continue the radiation?
No, you can't go. That will happen only if there is a pile invasion. So in that situation, next you have to enter into the brain tissue, which you are not supposed to do.
Okay.
But that is a poor prognostic factor. That is a poor prognostic factor, I would say.
Okay, sir.
Leave it. So that was the bulb area. Okay.
Okay. Okay, sir.
Wash.
And one other question from the delegate is, what is the margin in dura in millimeters you need to get?
At least 3 millimeters. We have sent for the frozen. We have sent for the frozen, but the 3 millimeter is considered adequate here.
Okay.
And to get that, I had to drill all around, you know.
That is why you went to the normal dura to find the drill all the bone around, right, sir?
Yes. See this little bit of the venous bleeding. I have to wash and see. I may use some Surgicel. I will not prefer to unnecessarily coagulate, which may damage ultimately the brain tissue. Wash, wash. Irrigate, irrigate, irrigate. Surgicel ready. You can see the entire brain surface healthy.
Yes, sir.
With no invasion. See that?
Yes, yes, yes. It's very clear.
I think 360-degree trace of tumor. Is that
Yes,
so?
sir. Yes.
360-degree, we don't see any trace of tumor anywhere.
Yes.
Okay.
So now what I'm doing.
So now we are waiting for the frozen reports?
Yeah. 15 minutes. Meantime, I will achieve hemostasis.
Yeah.
I will raise the flap.
Mm-hmm.
See this?
Yes, sir. Beautiful.
Entire region.
This is the 70-degree scope, right?
See, I'm going all around to see.
Yeah.
Intradural plane. Okay.
Yes, sir.
Now, Surgicel. Irrigation is one of the robust method of hemostasis.
Yes. So warm irrigation, right?
Pardon?
So warm irrigation.
Yes, yes. It is always better.
Yes.
Warm saline irrigation all the time
Yes.
for hemostasis.
Yeah, in a skull base, it is always इतना बड़ा दे दिया यार.
Yeah, true.
Scotch piece. See, the area is ready for reconstruction.
Yes, sir. Beautiful. Yeah. Wonderful.
So this is R0 resection. Called process. Okay, no bleeding, nothing.
Yes,
0
sir.
degree.
Absolutely.
0 degree. Now, meantime, we'll raise the flap.
Yeah.
Dr. John Shadow is saying amazing dissection, wonderful to watch. He has been watching all the webinars live
Oh, thank
from
you.
Australia.
Now see with the 0 degree. Until now, I was using 70 degree
70.
all the time. Now 0 degree, this is inside the see this. No bleeding. So now
Yeah.
my next part is raising the flap. And see we know the upper part of the septum is already, you don't have. Anteriorly
Yeah.
we have. What I will do, let me give me the scissors. I will get some more space. Trim this turbinate.
Yeah.
The inferior turbinate.
Yeah.
पतला दे यार, इतना मोटा देते क्या? See now you have adequate visualization. Wash कर दे.
Yes. Yes.
Of later. See, whenever you resect the inferior turbinate, see, this is a very important message. This is the posterior end of the turbinate.
Yes, sir.
Staying 1
Yes.
centimeter anterior to the posterior end is the turbinate vessel here. Must coagulate.
Okay. Okay.
Yeah.
Must coagulate that region. See that? Completely.
Yes, sir.
This is one of the causes for readmission with bleeding.
With bleeding. Yeah.
Later. That is the stump of the middle turbinate. See that?
Yeah.
Okay. Now I will raise a wide flap, broad flap. I told you.
From the floor of the nose.
Colorado.
Yeah.
Yes. Now see, from here, I will come laterally. Anteriorly, I will get the height of the septum also. I don't
Yeah.
go much laterally. I can take the entire inferior meatus if want. See?
Yeah.
Hello?
Yeah.
Yes,
Yeah.
sir. Yes.
But anteriorly, that much will not be required because you get the septum length.
Yes, anteriorly.
Yeah.
Section periosteo.
Here you have taken quite anteriorly also, no?
Pardon?
The Hadad has taken up to quite anterior part of the septum.
Yes. Because anteriorly the septum is preserved.
Preserved and wider. So this raw cartilage which is left uncovered, will it not invite crusting?
Yeah, it does, but
Yeah.
initially few weeks, that's why we advocate thorough saline irrigation, some crusting debridement. If you do it properly, it doesn't bother much.
Yeah. And you can ask for that putting mustard oil, boss, also. That helps a lot.
Yes, sir. That will
Crusting.
definitely help. I like
Yeah,
your
yeah.
idea. I like your idea. That will definitely help. Accumulation of the
Yeah.
crust
In
will be
post-op cases, I have seen, yeah, over last 10 years, Satishji, I have seen the crusting is almost reduced and synechiae incidence is almost gone, because here people lost to follow up. So sometimes they used to come back with synechiae, but once my assistant explained to put oil in a proper way, that incidence has definitely gone back. So
yes, yes. See the
can try and have the feedback, boss, because yours is a high volume center. So yeah.
Definitely, I will get back to you, sir. I will give you the feedback.
Yeah,
See,
sure.
I have taken the part of the floor, not much.
Floor.
But
Yeah.
one can take as much as you want.
Yeah.
You can go and take the entire lateral wall flap also.
Yes, yes, sir.
So these Jain sir, Palaniappan sir requested to demonstrate a case of pericranial flap sometime.
Yeah, yeah, definitely.
Yeah.
That is much simpler. Very, very robust, reliable, and the huge. Any defect can be, taken care of right up to the foramen magnum with pericranial flap.
I think in our webinars we have not yet done it, no?
Sir, I have scheduled a webinar in the coming time for the open approaches.
Okay, that then it will be coming. That's good.
Yeah.
Yeah. Yeah, yeah.
Yes,
Sure, boss.
yes.
Also, Professor Majumdar asked whether I have seen any case of aesthesia with distant metastasis.
Yes.
Because he has never seen a case of distant met. So
No, distant mets can happen, but in olfactory neuroblastoma, they come very late.
okay.
Very late. See, I'm separating the floor. Floor periosteum is very tough. Junction of the septum with the floor. ऊपर सेट रेडी है उठाए हाँ अंडर करा दो ये क्या नाम है हरिओम Now let's see if wants more length, will more elevate. Okay. Can you see?
Yes, sir.
See, it is adequate.
Yes, yes.
Agreed or not? Hello.
Yes,
agreed,
sir.
sir. Agreed.
Completely covering the defect.
So, give me calculator. So this, I took a little bit of the risk today to elevate the flap in the end. Oh. Calculator. See now the area I have elevated. Hello?
Yes, sir.
See the floor has been included in the flap. You can elevate this entire inferior meatus. You can elevate the entire lateral nasal wall completely. Completely along with this. Sometimes these cut ends keep oozing in the post-op. Kira? Negative. Frozen negative. Hello?
Yes, sir.
Yeah, thankfully frozen is negative.
Wonderful, sir.
So now, public, we have to start the reconstruction. The floor bleeding should be thoroughly coagulated, otherwise it can seep on, in the throat and post-op gives problems. So this is about the flap. Let me little bit more length I should give it to it. बंद है. The osteo. See, giving some additional length. Hello? Hello?
Yes, sir.
This was to give some additional length.
Hello?
Yeah, that was to give some additional length. Okay. Now we are ready with the reconstruction part. Okay? 70,
Yes.
70. Fat. And surgery cell ready, huh? Any question, Udbhav? You can take meantime.
So we have covered almost all the questions. And so many people are thinking this is an edited video because they are not able to believe how wonderfully you have done it.
Pardon, can you repeat?
So some people are thinking you are showing the edited video. They are not able to realize that this is a live dissection.
Oh.
So Dr. Ramakrishnan wants to know nasolacrimal duct opening.
Here we didn't go to that region.
Yes.
In this case, we didn't go.
It is far.
I have shown many times in the Denker's cases. In Denker's, we transect the duct.
Yes. Yeah, it is far anterior. Yes.
Sagittal. Oh, sagittal. More than I. See, this is same. Rifampicin sogged fat. See that? Yes.
So doctor, so many people want to see more of neck dissection webinars in future.
Neck dissection?
Yes.
Okay, sure. No,
Wonderful dissection, boss.
Okay. Hockey? It is not hockey. Give me
Deepak Sagar has joined.
Who?
Satish.
Yes, sir.
Wonderful dissection since morning.
Arey, sir, nothing new for you, I know.
No.
Give me Sagittal.
Remember one of the first ever cases you had done in Quad Road Hospital with Madhu?
Yeah, I remember long back.
Yeah, long back. Superb dissection.
See now, I will seal the corners. Okay. Or the see, you have to pass underneath the dura. See? Or the exposition. Other.
Dr. Ganesh from Chennai wants to know without cobbler, is it possible to do such cases?
Yes, you can, but cobbler gives you opportunity to. It gives you multiple hands.
Yes.
Your surgical time is much reduced. Your visualization is better maintained because of the constant irrigation.
Yes.
The collateral damage is much lesser. And it expedites the process. It expedites. It has
and as Satish
all the
would say
channels for suction. Sir?
It is a versatile bipolar with suction and irrigation.
Yes.
Because using bipolar here, many times keeping the prongs apart is such a difficult exercise.
Okay. See, this corner I have pegged. Okay, sir. Deepak sir?
Yes, boss.
Not celebrating Dussehra?
No, I saw you. See, that's what I want to tell the audience. The speed with which you remove the tumor in the first 1/3 of your surgery, because you could do that fast, this step you can do slowly and deliberately, isn't it?
Yeah. Here you need time.
Very carefully, because you don't want to have a CSF leak.
Once
So,
you reach the skull base, at the time of tumor removal, reconstruction, it takes time.
That you told in the morning that Rakshas banna padta hai.
Ravan.
The Ravan Rakshas bhi bolta hai wo. We have seen him tell it when he does a maxillary swing for a huge angiofibroma he used to do. At one stage, he would do it like that. So because that first 1/3 he did briskly, now he is doing it so carefully, because CSF leak after all this hard work, he is frustrated.
CSF leak is pathetic.
Yes, sir. Wonderful point, sir. Yes.
See, using this Surgicel to hold the fat is a great move, I tell you.
Yeah.
Not only it allows the fat to be staying in the place, allow it to be handled much better.
Yes.
It invites the fibrosis which we want.
Yes. It causes a bit of local inflammation, absorbs blood.
Now see,
so even the
I have
fibrin,
introduced this Surgicel between the dura and the fat, everywhere. This Surgicel swells up. It has the ability to swell up, It swells up and it holds everything in place. It makes it watertight.
Yeah.
That is the beauty. See, everywhere at the margins.
Yes.
It will swell up and seal it watertight.
And what's important for the audience is how he's undermining the whole thing under the edge of the dura.
बड़ा फिश है थोड़ा छोटा कर.
Satish.
Yes, sir.
What better celebration than seeing an olfactory neuroblastoma?
Olfactory neuroblastoma is a Ravan, been killed today. Ravan been killed today by endoscopic killing of Ravan.
Yeah, and Rajiv, this is a beautiful surgery because both ethmoidal arteries being handled.
Yes,
and
right.
that clean cut you place on the normal dura, and then you make the fox cerebri fall. I think he did it picture perfect. And maintaining the margins 3 to 5 millimeters.
The same case was done almost 4 months back in the webinar.
Yeah.
There's a revision for all.
Sir, many people are asking, is this a live surgical demonstration? They are confused. They are thinking it's a edited version of a video.
A real-time video bhi itna hi rehta hai na? So, and I think they enjoyed him doing the fess on the opposite side in about 3.5 minutes. the normal
Yes.
side, in
Yes,
one
right.
normal side.
You have to make it watertight.
Yeah.
पकड़ दबा नीचे नीचे.
But the post-op follow-up is very important in these cases. Especially after getting histopathology report, they should go for proper follow-up and with the.
But see, Rajiv, that point which Satish made in the morning, what's important is trying to go for as total a tumor excision as possible.
Yes, yes, yes. That's
Then
like
only
one of
the
the.
radiotherapy works effectively and patients get a good long tumor-free period.
See, once you enter intracranially, you are not able to remove a tumor completely.
Yeah.
It can result in the leptomeningeal spread.
Yes.
So many reports, so many times reported.
Yes.
Yeah. Sir, Dr. Tibor from Budapest is asking, wonderful discussion. Any use of facial lata in these cases?
Yes, yes, yes. About this, facial lata. See what I have done.
Okay.
Between dura and the fat, Surgicel.
Okay.
See, this Surgicel will swell up and make it watertight. See
Yes,
this?
water.
See the pulsations of the brain will be transmitted properly only once it is watertight. See that?
Yes, yes.
Yes.
Now, I will use a graft over it.
Sir, Dr. Talat from Pakistan is saying he has seen first time olfactory neuroblastoma removed endoscopically.
Really?
Yes, sir. From Islamabad.
He missed our fifth webinar, I think. In fifth webinar, he did.
Yes.
Rotate. So now I will cover with the, fascia for the reason I will tell you. To hold this entire thing inside, this my fascia will horizontally go beyond the margins. I will show you. This is an important strategy to prevent dislodging the previous material. Khol risk. Okay.
The fat from the thigh, Satish?
Yes. Fat from the thigh, and this is facial lata.
Yeah.
Again, soaked in betadine and.
Rifampicin.
Rifampicin, all rifampicin. Yes. See now. My flap is going to come. So what I will do, I will ensure it beyond the margins on the orbit horizontally to keep the material pressed.
Okay. You would be putting it as an onlay or would you undermine it again?
Only.
Only.
I will tell you the reason.
So by putting this facial lata, we will be covering raw area. So when we will put the Haddad flap, it will be hampering the placement of the flap?
Not really. I will show you. Your point is valid. Let me show you how.
Flap will give the vascularity. It will improve the vascularity. Haddad flap will increase the vascularity.
The vascularity is coming from the Haddad.
Okay.
Yes, that's why.
Okay, now.
And as long as Haddad is the final layer, there should not be a problem.
Yes, yes.
In fact, before we were using this Haddad, we were putting these free grafts only.
This I want to place horizontally from orbit to orbit.
Okay.
this is being placed in a different direction.
It looks easy, but it is difficult to put the graft in these cases.
Yeah, it takes a minute or two.
Now, if you're using a two-hand technique, then it's relatively easier. Yeah. And if you notice, it was rolled in something before.
See this.
And placed inside.
Graft is coming from one orbit. See, the part of it is lying on the orbit.
Absolutely. Yeah.
This is not inlay.
This is only, yeah.
Inlay is already very good. I am happy with that.
Yeah.
This is to cover horizontally
the
surface and make.
Amazing.
See, coming on the orbit both sides.
Yeah.
See, like this?
Yes.
Anteriorly,
Yes, sir. Beautiful.
Beyond the margin anteriorly?
I think on the left side, it is coming on the bone, and right side, it is directly on the periorbita.
Yes, because there is no bone.
Correct. Yeah.
But this is tension free.
Yeah.
Lying on the surface, solid, you know?
Yeah, and covering like a good blanket all around, complete.
All over to hold the inner material.
Yeah, the fat and the surgical both are held in one.
Give me the glue. This is a very important material, you know.
Just to hold the tissue in the plane, not I think.
Yeah.
For some time.
Ball probe. See, that is my frontal.
Yep.
Okay.
Yeah.
Now see, it is holding so well.
Yes.
It cannot be displaced because lying on the orbit both sides.
Yes.
It will hold like anything.
And again, one significant point is you are leaving both the frontal and sphenoids open.
Yes.
So mucoseals don't happen. Yeah.
Yes, and that you have to ensure in the post-op as well.
Yes.
Now, everything sealed? No leak?
Yes, sir. Yes.
Now what you have to do is reinforce.
Yes.
Now your job of the flap has become better.
Yes.
Tear in the flap doesn't make any difference as long as the vascularity is maintained.
Yeah. And again, you are not putting it as a primary layer. No, you are putting it as a fourth layer.
Yes.
So the vascularity, it should help really completely taking care of the seal. If you're putting it as the only layer, then maybe the tear would have mattered. But now, no.
No, it is not hampering the blood supply.
Yeah.
And it has a good base below.
Yes.
Of the fascia.
Yeah.
See my flap? Without any tension, reaching all the way.
Yes.
All the way. See the frontals above.
Because if it is taken well the way you have taken it, it becomes a 7 centimeter long flap and in the midline.
I think that's the reason Dr. Satish wanted to take the flap at the end.
Pardon?
To assess the required length and all.
I didn't get your point, sir. Your voice is breaking. Can
Voice is not clear, sir. I think net issue is there.
Yeah, net issue maybe.
See
I
now.
think that's why you took the graph at the end. Hadad, you raised hand because you wanted to be sure how much length you are wanting.
Yes. See now. I have a,
Yeah.
repair with a fat, with a gel form, surgical
Surgical,
at the margin,
facial atta,
with the glue and fascia holding across like a cuff,
and finally the
and
hadad.
that fascia is pressed in the center to hold.
Yeah.
Everybody is holding each other. See this?
Yes. Yes.
See now, it cannot move. No pressure can be transmitted because the fascia is there sandwiched in between. A thick fascia. Can you see?
Yeah.
How do you see this repair?
Fantastic, Satish.
This cannot move.
This is very good. This is very good.
So many, sir,
Yeah.
such repairs, and I found this way of doing had
Yes.
definitely improved our results.
Yeah.
See, it is lying so freely, no
Correct.
tension. This is the
Yes.
sphenoid sinus, that's the sphenoid sinus, both sides.
Yeah. Yeah.
And the frontal above, glue.
I think it's very important to take a good hadad flap.
Yes.
Longer the better.
Only this edge I have placed my glue, whatever I have left with.
Yeah.
To hold the anterior end. That's it.
Yes.
Or some more I will place all around to hold the graft.
Yes.
See, it's a, I would say, rock solid repair.
Satish, putting the T seal in stages, do you change the needle for it to avoid getting hardened?
Every time you have to change. Because it dries up.
Yeah.
Clogs. See now the final picture. Give me the gel form. Now finally you have to support this. That's it. See that?
Yeah. Are you going to put gel foam over this?
Yes, yes.
Yeah.
All those things which I did earlier.
Yeah.
Studio. Gel foam swells up and exert even pressure.
Yeah.
ये नहीं उतारे गिल्ला है क्या हाँ
So now 0 degree. See the repair.
absolute firm.
वो मेरा सेल 2 दिन आ गए This is the non-sticky layer.
Yeah.
और देख. And,
so to quote what you used to say when you taught me FES, ekdam tagda.
Tagda. See now, 2 vertical pieces of Merocell.
Yeah. And you remove this after a week or how many days?
4 or 5 days.
5 days.
See both sides one.
Yes.
It will swell up.
Yep.
And I will put half Merocell perpendicular to it coming out to the anterior nares.
Yes, yes, yes.
To hold them.
Yes.
See, it swells up. This is povidone iodine.
Yes.
And this will be supported by
2 horizontal pieces.
Yes.
Yeah, I'll do your mimicry. Boss, ekdam tagda.
Oh, mimicry. See this. This is going to press the inner one.
Interlocking type. Deepak? Deepak
Hi, Prakash sir.
Yeah.
Happy Navratri to you.
Same to you.
I saw you very active since morning. Narayan Jaishankar was there, so I didn't get into the audio. And once Narayan left, then I thought we'll give company to Satish boss.
Feel free to come anytime. Your comments are most valuable.
Yeah.
So now finally, the same Merocell holding.
Do you put a lumbar drain or anything in this, Satish?
Not required, sir. It is not high pressure.
Okay. And acetazolamide postoperatively?
Yes, we'll give Dimox, definitely.
How many days?
500 milligram 4 times a day to begin
Okay,
with.
500 4 times. Okay. For how many days?
Then we'll keep reducing. Once it
Okay.
heats up.
Yeah. Do you give phenobarbital? No.
Hello. Hello.
Hello, yes, sir.
Yes, we can get you.
Yes, sir. Can you hear me?
Yeah.
Sir, Dr. Talak wants to know the post-op care about the nasal douching and other things in this case.
We start once we remove the pack with the saline irrigation. And that goes on for a few months. And we'll subject him to radiotherapy once it heals after 4 to 6 weeks.
And endoscopic cleaning once in a week or once in fortnight?
Initially, no cleaning, no mechanical cleaning until first 10 days. Because it may scrape out the mucosa. After 10 days, yes. And now I'll start putting the, as Prakash Mukha sir said, the mustard oil.
Okay.
Oh, thank you, sir.
That will, I am sure, will reduce the dry crusting.
Yeah.
Now, coming to the next case, sir, do we go ahead?
Yeah.
Yeah, please, sir.
Yes. So this patient, let me tell you, which one is this? Okay. Yes, this patient is a biopsy-proven sinonasal adenocarcinoma. Sinonasal adenocarcinoma is a different entity. After squamous cell carcinoma, this is the second most common sinonasal malignant tumor. Let me first take you through the radiological findings. Hello?
Yeah?
Yes.
Yes, sir. Go ahead.
So after the squamous cell carcinoma, this is the second most sinonasal malignant tumor. First, look at the CT scan. As I showed you earlier, CT can give you information like, and this is a revision case. This is a revision case.
Okay.
Got operated somewhere and the biopsy revealed adenocarcinoma. It was taken up for sinus surgery. And then the surprise finding was a tumor.
Suppose they had done an MRI with contrast,
Yes.
they wouldn't have been caught by surprise, no, Satish?
No, what happens, sir? These patients present with a polypoidal lesion.
Okay.
And no wise surgeon can consider this as a polyps and take up for sinus surgery. This happens it's not uncommon.
But don't you think in the last 2 years, our reliance on MRI and MRI is increasing, even in this
Sir,
apparent polyps on CT?
the role of CT scan is just limited to bony details.
Yeah, yeah.
Anything else is shown by MRI better,
Yeah.
except bone. So the role of CT scan in our practice is limited to the benign sinus disease, chronic rhinosinusitis,
Yeah,
and
yeah.
benign chronic ear disease. That's
Yeah,
it.
yeah,
Where we need bony details.
Yes.
Except that everywhere is the MRI, which gives so many details because of so many sequences
Yeah.
can give.
Because even all these polypoid lesions, which look polypoid on endoscopy,
Yeah.
I don't know whether detecting it more or whatever, but many inverted papillomas you will see on the table.
Yes.
So instead of being caught by surprise,
Very commonly
it's
inverted papilloma are diagnosed like this.
yes, it's worthwhile doing an MRI with contrast.
Yes.
It saves you a lot of trouble on the table.
Yes. So this was taken up for sinus surgery and it revealed adenocarcinoma.
Yeah,
Now, what CT scan is revealing? This is a soft tissue. It's an opacification, nasal cavity, destruction of the septum, the sinus opacification, orbit intact, and this is reaching to the cribriform plate. See this?
Yeah, yeah. These
Looks
are the
like
soft
AD.
tissue windows, Satish.
Yeah, this is soft tissue window.
Yeah, the bones are looking thicker.
You can see the brain.
Correct.
Yeah.
See the soft tissue, the muscles around.
Correct. Yeah.
I can convert to the bone window here.
Yes.
Now I have converted to bone window. Look. See.
Okay. Okay.
You can do on your software.
Yeah, yeah, yeah.
No soft tissue is visible now.
Correct. Correct.
Pure bone window.
Yeah.
Okay.
Yeah.
Now, I request everyone to order CT or MRI with all required sequences in DVD to get adequate information.
Yeah.
Otherwise, in printout, you get less than 5% information.
Yes,
in
obviously.
Printout 3 or 4 printout, you get 60, 70, 80 slices.
Yeah.
Which otherwise are in thousands. And that too, a static information, not a dynamic one.
Yes.
Yeah.
Now, coming to the, the MRI. I told you like previous case, see on MRI, the disease, the tumor will appear hypodense.
Yes.
And secretions will appear hyperintense.
Yes. Yes.
Can you see? Multiple cystic spaces.
Yes.
This sinonasal adenocarcinoma, I will take you to the pathological part. This is a number of varieties. There is a classification from, salivary, non-salivary into intestinal type, non-intestinal type, intestinal type into 5 types, non-intestinal 2 types. This particular tumor is an intestinal type sinonasal carcinoma of mixed variety. Mixed variety has a reasonably good prognosis. Not the best one. And you will find multiple cystic spaces as well.
Yes.
And this is what you see on this
Yes.
MRI. Okay?
You got a IHC study done for this, Satish? Or
Yes.
it's on that you're...
Yeah.
Okay, yeah.
It was CX20 positive.
Okay.
I will show.
Yeah.
Then, see, this sinus, maxillary sinus not involved. Tumor is lying in the cavity. Tumor is lying in the ethmoids. See this? Ethmoids are the commonest site of origin of sinonasal adenocarcinomas.
Yes.
Unlike squamous cell carcinoma, where the maxillary is the most common.
Yes.
Now, see, I am coming from anterior to posterior. Anteriorly, see the secretions in the frontal sinus because of blockage.
Yes, secondary.
Blockage of the ventilation drainage.
Yeah.
Now, this is only thing which is giving me doubt of
Dural involvement.
Dural involvement.
Dural involvement.
See the thickening. Let us see, and this is frontal recess. This is all secretions mixed with tumor everywhere.
Yes.
And multiple cystic spaces.
Yes.
Okay. And as you go behind, see the sphenoid sinus is pretty clear. On one side and other side secretions. And tumor is hypodense below. Okay?
Yes, sir.
So nothing in the sphenoid, nothing in the postethmoid. It is in the anterior ethmoid, nasal cavity and towards the skull base. Now see, let us put the contrast together. That is the beauty of MRI on the software. Now, let me put the 3D contrast together. See this, running together.
Yes.
Now, let me start from beginning here. What we saw on T2, let us correlate on this thing. This tumor.
Yes.
Now see, the hyper intense secretion in the maxillary do not enhance on contrast. That means it is secretions.
Correct.
See the cystic spaces in the tumor. Can you see this?
Yes.
Do not enhance.
But here the dura appears to be free, na Satish?
Here, the dura, I don't see the differentiation, clear-cut differentiation from the dura. See this.
Okay.
This
this area you can't,
This is tumor, this is secretions below, which are not enhancing.
Yeah.
See, the tumor is enhancing, but not the secretions. And tumor is along the cribriform plate.
Yes.
See, what happens, even these adenocarcinomas, which arise from the ethmoid, they mostly arise in the olfactory cleft.
Yes.
And their removal warrants a one layer extra as a margin. Like, for example, if they are attached to the olfactory mucosa, ideally, we should remove the cribriform plate as a margin, not the dura.
Okay.
If the dura is, if the cribriform bone is involved,
then dura has to be removed.
Then it should be removed along with the dura.
Yeah.
It should be to stay on the safer side to get a free margin.
Yeah.
So, this is tumor which is along the skull base, and these are the cystic spaces which are not enhancing.
Yeah.
Okay? Now, as you go behind.
Yes, sir.
All these cystic spaces, no tumor. See this? The sphenoid is full of secretions on T2.
Yeah.
Doesn't enhance, means all secretions.
Yeah.
It is not going beyond anywhere. It is not entering into the orbit. See the orbital surface all the way.
All these areas, the dura is clearly away.
See the orbital surface all the way.
Yeah.
See this black periorbita is the layer. See this layer.
Yes.
These are extraocular muscles.
Yes.
White, bright is the fat.
Yes.
And this dark is the periorbita and the bone. And it is pretty intact. See this?
Yeah.
All the way.
Yeah.
So no question of orbital involvement. There is certain principle you can see on MRI.
Yeah. I think the left cribriform plate is the key.
Yes, that is the only doubtful area.
Yeah.
On MRI, there is a simple principle. On any sequence, bone is always dark, air is always dark, fat is always bright.
Yes.
On any given sequence. Rest can be different.
Yes.
So, in the orbit, this is all fat inside.
Yeah.
Dark are the extraocular muscles which enhances on contrast. See this?
Yes.
Yes.
This is a very, very important sign. The region
and
is...
even the secretions are bright in T1 and they are dark in T2.
Yes.
Correct.
Secretions are bright in T2, sir. This is T2.
Bright in T2.
Okay. Okay.
Then why do we always see this enhancement of the extraocular muscles? Because sometimes these tumors at the orbital apex, if they happen to involve the nerves at the orbital apex, this is muscle atrophy starts and they do not take enhancement. And that is an indirect sign that the tumor is involved the orbital apex.
Yes.
So
but yet they are taking good enhancement. Yeah.
Yeah. So one must always look at enhancement of the muscle to rule out, involvement at the orbital apex. So this is the tumor. Now, as I said, this is adenocarcinoma. Adenocarcinoma, I told you, adenocarcinoma, as I told you, are divided into salivary and non-salivary type. And in the non-salivary, the commonest are the intestinal type adenocarcinoma, where the histopathology is like colonic carcinoma. And the others are non-intestinal. Non-intestinal type are defined as by exclusion. When this is not salivary type, when it is not intestinal type, then it is non-intestinal type, you can say. And out of them, there are 5 varieties of the intestinal type. This is important to understand because every variety has a different biological behavior with different treatment protocol, prognosis, everything is different. And out of these, the solid and the mucinous have a worse prognosis, and the high-grade tumors in the non-intestinal have a worse prognosis. And this intestinal is always occupational related, particularly in the hardwood dust or leather industry. People exposed to hardwood and the leather industry for years together generally develop this intestinal type adenocarcinoma. Can you hear me?
Yes, yes.
So why this is important to know? If it is an intestinal type adenocarcinoma, because of the occupational exposure, what happens? How it happens? The normal Sanadarian mucosa of the nasal cavity is, it converts to the metaplasia happens to occur because of the chronic exposure of the wood or leather, whatever, and converts into pre-neoplastic mucosa, from where the tumor starts. So ideal principle in this tumor intestinal type is to remove the entire ethmoidal mucoperiosteum as a whole, because it becomes carcinogenic. It's a sort of complete removal of the mucosa to prevent future tumor formation. If you try to go to the site of attachment only, you may miss the rest of the carcinogenic mucosa, and the tumor can again develop from the other area. So it should be like a carpet clearance of the entire mucoperiosteum of the ethmoidal box in intestinal adenocarcinoma. This is bottom line. This is so important. It's not like previous olfactory neuroblastoma, where we go to the site of attachment and go around with a margin and remove it. In intestinal type, like the left side, it is predominant. At least left side, I will remove this entire ethmoidal block mucosa as a whole, wherein the mucosa has become hyperplastic, neoplastic, pre-neoplastic, which has given rise to this tumor. I don't have to wait for the tumor to come back in the rest of the pre-neoplastic mucosa by leaving that behind. So in intestinal type adenocarcinomas, one must remove the complete ethmoidal block mucosa. This is must to give a complete carpet clearance of the area which is exposed to the carcinogen, that mucosa which has become pre-neoplastic, which has given rise to this kind of adenocarcinoma. Unlike Deepak sir asked about the markers, these intestinal type are classically positive for CK20 and CDX2, and they have like other sinonasal, this thing, neural crest tumors. Sometimes they are.
Yeah.
Hello?
Hello? Yes, sir. Yes.
Hello?
Sir.
Yeah, and another important thing, to always ask your immunopathologist to do CK7 testing. Because if it is positive for CK7 testing, then it confirms the sinonasal adenocarcinoma, intestinal type. If it is CK7 negative, then you have to rule out the colonic carcinoma metastasis. Got my point?
Yes.
Oh, that's a
Yes,
very
yes.
significant point.
That's a
I
very
think that
important
differentiates the
point to look
primary from
for.
a secondary.
Yes.
Okay,
So one must
CK7.
look for CK7. If it is negative, then must look for the colonic cancer metastasis. So this is a simple, profile of the adenocarcinomas we must know. And the beauty is you must do a carpet clearance at least on the ipsilateral side to give a complete radical clearance to prevent relapse. So treatment, the bottom line is surgery. Radiotherapy has hardly any role, but yes, in advanced tumor, like any other pathology, radiotherapy is given as an adjuvant treatment, but not as a primary treatment at all. Adenocarcinomas are surgical entities. Any questions?
Can you show the exact site of this origin of this carcinoma in the scan?
In scan with this much of the tumor, this much of the advanced tumor, you can't make out the site of origin. But I told you,
yes,
they mostly arise from the
olfactory cleft. Yeah.
Yes.
There must be somewhere in this region.
So attachment will be superior.
Yes, and let's see what kind of clearance they need. I told you we have to go one step ahead. One step ahead for the clearance. There are variety of surgery in the olfactory cleft. You can see. See this. For a simple small tumor attached in the olfactory region, you can just do a simple olfactory cleft mucosal resection only. If it is beyond partial resection of the olfactory cleft, total resection, complete, unilateral, complete endoscopic and skull base resection, and in the last one, what we did, bilateral endoscopic anterior skull base resection. So depending upon the extent of the tumor and the need of the margin, you have to take a call. Sinonasal malignancies have so heterogeneous histology and number of histologies. So these tumors should be thoroughly evaluated histologically, immunohistologically to reach to a correct diagnosis. Otherwise, a slightest mistake can change the overall, management. Any questions?
No, sir, I think we can go on with the surgery, sir.
अरे उस बेचारे को थोड़ा चाय पानी पीने दो.
No, I'm fine, sir. The case is ready. In couple of minutes.
That's very correct.
The case is ready.
Okay.
Sir, Dr. Nadia wants to know indication for open surgery. If it is involving the skin of the face, then we need to do open or we can go endoscopically.
Indications for?
Open approach in this sinonasal malignancies.
See, by and large, I mentioned last time, by and large, any involvement of the orbit, massive involvement of the brain, anterior soft tissue involvement, anterior frontal bone involvement, all these are indications for open approach.
Yes.
And beyond that, involvement of the orbital apex, cavernous sinus, carotid artery, these are sort of contraindications. But nowadays, with the advancement in the, surgical technique, there's no contraindication. We have done tumor involving the carotid artery by completely coiling the carotid artery and complete cavernous sinus resection in a patient with a blindness, with all cranial nerve resection and with a combined approach and complete cavernous sinus resection. So sometimes you have to do, otherwise these patients are going to die. So with counseling, with if feasibility is there, you have to take a call. Any other questions? See, these, as I said, have a heterogeneous histology. In coming time, we'll cover one by one. See, why I kept this adenocarcinoma, because this requires a different sort of treatment than olfactory neuroblastoma. Then we'll keep sometimes the squamous cell carcinoma with variety of situations, because squamous cell carcinoma again has 5 varieties of histology variants. Every variant has a different outcome, different need of treatment, different, sort of prognosis. So that requires a different extent of resection as well sometimes. Sometimes even the orbit is slightly invaded with a low-grade histology. You can think of preservation of the orbit with taking the adjuvant therapy, bringing the adjuvant therapy in role. But in the high-risk cancers, you can't. So many things are required to be taken into consideration before decision making. So as I said, we have a webinar after the ISOCON on open approaches. This is very important. Even this in endoscopic era, one must be well versed with certain important open approaches. You may have to resort to open approaches sometimes intraoperatively. So those are equally important even in this endoscopic era. Vinod, Felix, anything to add on, please?
Nothing, sir. We are waiting for the surgery. Please take some break and come back.
No, I am ready. The case is getting ready in a minute or so. So, one thing I wanted to ask, you do a lot of cavernous sinus. I have seen your videos a couple of times. Any time you have done for the malignancy?
No, sir. We have never done for a malignancy so far. But I think, as he told, in certain malignancies, with coiling and bypass, it is feasible. The patient is ready to take the risk of that surgery.
Yes, the malignancy, because the game is altogether different.
What sort of malignancy have you operated endoscopically in the cavernous sinus?
All, if feasible, if it fits into the, the indications, all. But as I said, the indication for open approaches. So, if required, open approaches.
But once the tumor goes into the cavernous sinus, how will you tackle the perineural spread? Even if you resect the cavernous sinus, there can be some perineural spread.
First of all, you have to establish the perineural spread. You have to establish the extension to the other areas, like, already the orbital apex is involved. Already ophthalmoplegia, blindness, already all these things are happening. Then you have nothing to lose. Then you have to do a radical resection of the orbital apex and cavernous. Because otherwise there is no treatment. What will you do otherwise? There is no other cure. So this requires a lot of counseling because so much of morbidity and mortality is involved.
The problem is, once the mortality is involved, it's very difficult to convince the patient for the surgery.
Yeah, it is really difficult. I understand. It is really difficult. Fully agreed with you. But sometimes you have to give all options to the patient, honestly, with pros and cons.
Yes, sir, that's right. True. There is one thing which I thought I should bring across in this webinar, sir. Because since I am attached with a cancer center as an honorary consultant, we get a lot of cases where the tumors have been partially debulked, and they send the case for further revision and radiation. There is some wrong trend going about in there.
That is never acceptable. It is never cancer treatment then. This is simple butchery.
Yeah.
Adjuvant therapy doesn't mean that you do an incomplete resection. The role of adjuvant therapy is adjuvant after complete resection.
Exactly, sir.
That's my point.
That's right.
It cannot work with an incomplete resection. There is no philosophy like that.
There are people who think that once you take the tumor bulk, the rest can be handled with radiation. There is an ideal treatment. There is some misconception like that.
Yes.
So, Dr. Apisha wants to know, do we need a more clearance margin in adenocarcinoma in comparison to squamous cell carcinoma, or the philosophy is same?
So more of
clearance margin more in adenocarcinoma than in comparison to squamous cell carcinoma.
Same. See, negative margins are always required, whatever malignancy you are operating. The surgical goal for any malignancy is to achieve negative margins anywhere in the body. Now, how you achieve negative margins can be different. इसको आगे खिसका दो. क्या हुआ? What? How you achieve negative margins may be different, like en bloc, piecemeal, whatever. But the ultimate goal is to achieve negative margins, and the radicality of the surgery is not affected by the piecemeal, because whatever piecemeal you remove is the luminal component. At the site of attachment, it is radical. Like in the previous case, at the site of attachment at the dura, we were radical all around. So that gives the same negative margins what you do with the open en bloc resection. So the definition of achieving negative margin, we must know. Can you connect to the endoscope? First, endoscopic picture. अरे शेरी बॉस आ गई क्या? बुलाओ और उसको ले लो. Hello, are you getting the endoscopic picture?
Yes, sir. No.
Okay, connecting. अजयपाल उनके आते ले लो, चालू करा दो. Let me know when the endoscopic picture comes, please.
Yes, sir. It's not. We are not getting.
What happened? Not yet. Connect, please. Yes.
Yeah, we got it.
Got it?
Yes.
So, पीछे करो यार. Now see the picture. See this kind of a mulberry appearance. See this?
Yes, sir.
Yes, sir.
Carcinomas are favorable tumors, let me tell you, as compared to the squamous cell and other malignancies. Particularly non-intestinal have a better prognosis, up to more than 90% 5-year survival, better than any other malignancy. In the intestinal type, the solid and the mucinous have a poor prognosis. Otherwise, rest enjoy a very good prognosis. So these are favorable tumors, and these are surgical entities, pure surgical entities. See what I am doing? Luminal debulking. I hope the picture is good.
Yes. A very clear picture here.
See the cystic areas. Can you see?
Yes, sir. Yeah.
These are cystic areas. This is classical of this, adenocarcinomas, where you'll find the mucin lakes. We call them mucin lakes. See this large cystic area. Can you see?
Yes, yes, yes. Very clear.
See this. Let me open it. See this large cystic area. And you saw in the MRI.
Yes, yes.
These are very favorable tumors. See multiple cystic spaces. We saw all these on MRI. First section. यहाँ रख आवाज आती रहनी चाहिए. Give me ball probe. See this secretions. We saw from the scan that these are just secretions. Okay, give me a pack and red 40 now. When you reorganize the instrument in between, you can put a pack to improve your field and then come back again. Wash. Okay. Remove. Give me a wash. Section. Straight पे लगा के दे. One more wash. नीचे नीचे कर. See now, the field is good.
Yes, sir. Yeah.
So you can in between improve your field, pack some area, focus in other areas. Now, I pack this area and focus on the maxillary and the orbital surface now. 40. So that is maxillary sinus. From inside it is fine. That is the reason of the orbital wall.
Yeah.
Hello?
Yes, yes, we can see the movement.
Wash. Wash. Section, wash. I'm still with the 0 degree only. See the cystic area?
Typical
Yes.
cystic area.
Yes, sir. Yes, sir.
See how many cystic areas are there? I am going very quick. See, again a huge cyst.
Yes, sir. Yes, sir.
See this large cyst.
Yes, yes.
See this material, mucin. See, this was going across the septum. See this kind of material inside. Can you see?
Yes, yes.
This is
It's a skull
classical
base.
of adenocarcinoma. Such lakes. See this?
First in the frontal sinus.
Frontal sinus. I am using only one instrument, debrider. That's it. Debrider with a good suction backup is the key.
Yes, sir.
ढोकला क्या होता है मैं भी देखूं
इसको अंडर तो करवा दो. Next. See, this is the periorbita. This is all now. I'm trying to remove it in toto. See the entire wall coming?
Yes, sir.
See the entire wall coming.
Yes. Yes.
Biopsy.
Sir, in smaller tumors, do you always make an attempt to make the removal into top and block?
Pardon?
In smaller tumors, whenever possible, do you try to remove the tumor in block, or you still go with the peaceful resection?
Doesn't matter. You see, in adenocarcinoma is a different ball game. I told you. Adenocarcinoma means you have to remove this entire mucosa. This exposure to, this is, as I told you, intestinal type. It is mostly because of the chronic exposure to either dust particles, the wood dust particle, leather fumes, all those materials. And these particles get trapped into the ethmoidal cavity. They make the mucosa neoplastic, wherein this tumor develops. This is classical of this tumor. So the goal is not only to remove the tumor, of course, and this is an amazing prognosis. See, all cysts have been completely removed. Now, this was the initial gross work. Now we come to the area wise. Give me cobbletter. Drill. Drill. So now this is the fine work that I will see each and every area. Section डाल लेना पानी ऑन है हाँ दूसरी लगा लगा पानी डाल See, this was gross resection. See, that is the region of the skull base. Can you see?
Yes, yes.
It is it has thinned out the skull base, but not extending inside. Give me the cobbleator first. See, this is the level of the anterethmoidal artery here. See this?
Yes, sir.
That is the frontal sinus. Above that is the supraorbital recess here. Let me open up to show you, just to show you. This one. See that?
Yes, sir. Yes.
And this is the olfactory cleft region. See, it was because of the cystic areas, this entire thing is eroded. And what I'm going to do here is, see, exentration of the mucosa is, wherever you can exentrate, remove. Wherever you can't, devitalize. Okay?
Any chances of CSF leak in future from this site?
Pardon?
Any chances of CSF leak from this site or factory area in future?
Not really. I will show you at the end. This is olfactory cleft. This is the skull base region, which I have. See, this is a thin layer of dura. The bone is already gone.
Yes, sir.
See the skull base? Olfactory cleft region?
Yes, yes.
Yes, sir. Yes.
That's a dura, right, sir?
Yeah, this is all eroded. Pressure erosion most likely. What I am trying to get is the entire devitalizing this entire region. My job will be done. Wherever you can remove the mucosa, remove. Section. This is carpet clearance.
Sir, if there is bony erosion, then we need to take out the whole bone around that bony erosion, or we can leave the bone.
Yeah. If the bone is already eroded there is no bone.
Yes. Yes.
No tumor because of the adjacent area of the cyst. This is pressure erosion.
Okay. Okay.
This is not invasion.
Okay.
How do you differentiate that, sir?
Infiltration is, that infiltration is passing through the layer. Many a time you see the cancer passing through and through.
Okay.
This is just, pressure erosion. See what I'm trying to do from this ethmoidal labyrinth? Trying to exentrate this mucosa, To me, there is a concern is not the tumor now, concern is the mucosa, Only ethmoidal mucosa, not everywhere. Right. Only ethmoidal. See this, all this ethmoidal labyrinth. So this is a different principle for this surgery. All this mucosa is carcinogenic. That's why we are removing it. Okay. Right. See all these cells in the ethmoidal labyrinth. लगा दी क्या पर? हाँ? That was the Heller cell. Exentration of mucosa, which we never do otherwise, to protect the mucosa in sinusitis. Here we are exentrating. And this is the only cancer in which this is required. One by one, each area. This is the part of the Heller cell. I will show you the entire area later on together. No, divider. Still a lot of things to go. See, this is ethmoidal roof. See the frontal supraorbital.
Yes, sir.
Then the anterior artery just behind the forceps. The anterior artery behind.
Sir, Dr. Fazal from Pakistan wants to know any adjuvant treatment in this case. After this, you need to give.
Yes. See, most of these patients, elderly patient, better to give. But young patients with this kind of disease, with this kind of radical clearance, with no intracranial extension, you can observe with a close follow-up.
Okay.
Because even if it recurs, you can revise it again and then subject to radiation. Radiation has hardly any role. See now, this is sphenoid now. This is sphenoid now. This is post-ethmoidal. See the entire area cleared. See the ethmoidal roof. This is what I wanted to clear. Radically. Karma section. And this is kar section. यहाँ कर. इसमें कर. यहाँ. नीचे. Divider, straight divider. And now with the sphenoid, I will not go radical. This is secondary blockage. We could see on MRI also. This is because of those cysts along the skull base. This redundant mucosa. That is opposite side. This is block because of the blockage. Retention. Adenocarcinoma means most of the work is microdebridor. Such a good favorable tumor. Brighter. Radically remove the mucosa. See, we went to the opposite side from behind. With the sphenoid of the opposite side. And this is the complete cribriform picture. Cribriform plate. Are you oriented? Hello?
Yes, sir, we are oriented. We are oriented.
See, this is the sphenoid of the opposite side, Dalpan. This is the ipsilateral sphenoid. This is the nasal cavity, the coin on this side, maxillary sinus. I have removed this mucosa along the ethmoidal box thoroughly. This is the lamina, this is supraorbital, frontal, this is skull base, the cribriform region. Opposite is clear. Opposite is clear. I don't have to go there radically. And this is the cribriform region or key area. See this? And this is just, there's no extension beyond this anywhere. Nothing. This is compressed because of the cystic masses. Give me cobblator.
So in adenocarcinoma, we need not remove the entire bony box.
Not really. You don't need to. See, this is, the bone is already, eroded. Let me show you. See this carefully.
Yes, I can see the dura there.
Yeah, see this bone is already eroded. But not by tumor. It is by compression. It's not infiltration.
By avascular.
Pardon?
By compression, avascular necrosis sort of thing.
Yeah. See the skull base. See this bone?
Yeah.
वो ले लिया ना? Okay, mom. See all these olfactory area. Cobblator.
Yeah.
This is all olfactory region. I can see the dura there behind. See, this is bone. You can see the dura behind. See this?
Yes.
See everywhere?
Yes.
Yeah.
Yeah. It's just pressure erosion. See the normal dura on this side as well? Can you?
Yes, we can see, yeah.
Yes.
But it was not going. You don't have to do anything. Whatever I am doing is a radical procedure. लेफ्ट है ना, देख लेना. So what you saw on the scan was, see carefully now. See, this was the area of the cribriform. See this dura?
Yes.
See this dura? And this was the mucosa over it which I coagulated. See that?
Yes. Yes.
There was no tumor going inside, not at all. See this, absolutely intact. This is something you need to ensure.
Yes.
Do we need to cover this area with any mucosal layer or anything, or any lab?
Not really. It mucosolizes, no issues. See, truncated, absolutely normal.
Yes.
Now see, this is frontal sinus, recess, anterothoracic artery here, the orbit there, posterior skull base, this is sphenoid. Fine. And this is the opposite. मेरे को straight लगा के. Let me give you a full wash and show you all the landmarks first. Then I will drill some areas. See, that is frontal area, recess. See the skull base. See,
Yes,
close
yes.
up.
Yeah.
Hello.
Yes, yes. Please go ahead.
Sir, ख्याल है.
And this is the ethmoidal roof.
Yeah.
Roof here. So this will be, I'll just spec for a minute to improve my field. अंदर. करो. Left first करो. Now just pack for a while and then reassess. Drill ready? See, this is skull base. Close up assessment of the skull base.
Yeah. Now, give me section लगाओ. What? अब मेरे को वॉश कर. कर अंदर.
Look at the skull base now.
Yes, sir. Yes.
See the frontal above? The entire cribriform plate here.
Yeah.
This one. Everything. See this one?
Yeah.
Yes, sir.
The last case, we remove this entire central cribriform. Right from frontal to the orbit, to the sphenoid behind, and then to the opposite orbit like this. Right? But here, this need not to be removed. Wash, wash. See how the pathology change the management.
Hmm.
This
Yeah.
is simply because this was intestinal variety of adenocarcinoma. In
Beautiful, sir.
sinonasal malignancies, it is always the histology-driven treatment. Had this been a rhabdomyosarcoma something, I would opt for the chemo first, rather than surgery, unless it is very small and resectable easily. See this, all mucosa has been resected from the ethmoidal labyrinth.
Yeah.
This is called carpet clearance. Can you see?
Yeah. Yes, yes.
This is
Yes, sir. Yes.
This is radical clearance. Back. Any questions or anything?
Wonderful, sir. Dr. John Shadow wants this. Hello?
Yeah.
Yes, sir. That polishing of the bone, he wanted to see, and you have demonstrated it very well after the removal of the tumor.
See, MRI is so useful. We knew there are multiple cysts.
Sir, Dr. Mohammed Radwan wants to know, do you counsel the patient about the smell, the loss of smell
Yes,
after
yes,
this?
always. Always. Once you remove the olfactory cleft, the skull base, cribriform, obviously the smell is going to go. Once it is malignancy, that is secondary.
And so what if the dura is happen to expose, then what to do?
Nothing, nothing. It will mucosalize. It is
Okay.
small exposure, the dura doesn't need anything. Otherwise, you can put a mucosal graft. Yeah, pack kar dena. Change karna udhar. You can put a mucosal graft or anything. Otherwise, need not to be done anything. Just saline irrigation, it will mucosalize without any issues. Any questions? कुर्सी देना कुर्सी
We have discussed most of the things, sir.
Actually, the way you explained hardly leaves any room for question.
Yes, sir. Yes, sir. Most of the questions are answered while operating.
Yeah.
Hello.
Yes, yes.
Yes, sir.
Hello. Was there any question?
No, sir. No.
I said you explained so well, hardly any room for any questions now.
Oh.
So no doubt, if one knows the subject, there is no doubt. And if he doesn't know the subject, then he don't have a question.
Yes, sir.
But I think we should appreciate Dr. Muga sir energy. He's with us.
Full of energy, sir.
Great.
And he always.
Thank you. Thank you.
And I think you should be given Man of the Match award for last 5 months webinar. All the you attend all the webinars. You just take part in all the webinars, not in this one.
He has always been active.
Basically, sir,
Man of the tournament.
Man of the tournament.
And still I am not started second half working, so I have the time. And that I find this is probably one of the best uses of our time. We got to learn something, got to know people, refresh our subject. So I think that's a better way of utilizing the time.
Ultimate.
Satish, can you throw light on the post of follow-up, when to do scans and other things in these cases?
In such endoscopy has the biggest advantage that you don't need to get the scan so frequently.
Yes.
The reason is you just put your endoscope inside the nose and see everything.
Yes.
Like for example, many a time why I on laterally placed tumor, why I do dankers. It's not only for the surgical access. That is amazing. Makes your life easy. Everything is head on. The most important thing is the post-operative, follow-up.
Yeah.
Just put your
Yes.
inside and you don't need any imaging. Otherwise, what is happening behind you never know.
Yeah.
Similarly, in such endoscopy skull-based surgery, you don't need to do so frequently any scanning because your endoscopy will tell you everything much before then the scan can pick up.
Yeah, that is what I was coming to. Your endoscopic direct examination probably has more value or weightage than imaging and all that.
Yes. So in patients when we have planned a post-operative radiotherapy after the completion of radiotherapy.
Yes.
Or I would say after 3 months of completion of radiotherapy, we get first scan done.
Yeah.
In patients where the radiotherapy is not planned, we get scan done after 3 months. Just one check scan in malignant lesions.
Yeah.
Then endoscopy will warrant you any radiology if required in future.
Yeah.
So now coming to the next case, the interesting story about the next case was this patient had hydrocephalus.
Yeah, we can see.
For which a stent, the shunt has been placed. Not only because of the hydrocephalus, because of the high pressure, he developed multiple CSF loculations within the brain. Let me show you.
No.
See this, multiple CSF loculations and various parts of the brain because of the high pressure.
Yes,
see the
sir.
ventricle.
Yeah.
So he was shunted, a ventriculoperitoneal shunt was placed. See the condition of the ventricles, dilated.
Yeah.
And in drive sequence, you'll see multiple CSF spaces everywhere in the posterior cranial fossa because of the high pressure. So it was better to get a shunting done pre-op. And see on simple drive sequence, MR cysternography, non-invasive. What you see this CSF?
Yes.
Coming here all the way in continuity. See this?
Yeah.
Yes, sir. Yes.
It's so obvious. See, in our practice, been years together that I have ordered any CT cystonogram. CT cystonogram is an invasive investigation wherein you have to inject a dye in the intrathecal space and then you pick up with the CT scan as the dye comes into the nasal cavity through the defect.
Yeah.
Now that dye we inject is a iodinated contrast. It has its own complications, number one. And second, it stays in intrathecal space for little time, 1 to 2 hours. And during that period, when you get the scan done, if there is active leak, then only it will pick up.
Yeah.
Okay. So if it is intermittent leak or the leak didn't occur that period of time, it will not pick up and it is all waste. And it may rather bias you with a negative report that there is no CSF leak.
Yeah.
Same is with the MR cystoscopy. What information, what you get with the CT cystogram, that when you have an active leak, why to get a CT cystogram done? CT cystogram will pick up only active leak at the time of scanning. If there is active leak at the time of scanning, you can pick up with the MR cystogram, which is truly non-invasive. What you are seeing is picked up. This leak was picked up during MRI, heavily T2-weighted imaging, MR cystoscopy or drive imaging, whatever you call it. Since there was active leak, it was picked up.
Picked up.
So if the patient has an active leak, there is no point in subjecting him to HCT cystogram.
Yes.
Problem comes when there is intermittent leak and difficult to pick up. So for that, we get gadolinium enhanced intrathecal cystoscopy. The reason is simple. The gadolinium, what we inject, diffuses freely in CSF, unlike iodinated contrast, reasonably trouble-free, and it stays in intrathecal space for up to 24 hours. So, on one MRI scan after gadolinium, if it doesn't turn up any CSF leak, since it is there in the intrathecal space for 24 hours, you can get repeatedly MRI done intermittently after 2 hours, 3 hours, 2 hours, 3 hours. Since MRI is radiation free, it has a high possibility of picking up an intermittent leak by repeated MRIs because the dye is already there in for 24 hours.
Yes.
So for intermittent leak, intrathecal gadolinium. For regular CSF leak, MR cystogram. There is no place for CT cystogram. So this is the leak, and now this patient was shunted 15 days before, and after that the leak has become intermittent. Now he leaks in between, not like before. Before was a continuous one, but now the pressure has been settled. The leak has become intermittent, but yet it requires a solution because the stopping the leak doesn't rule out the possibility of meningitis. You have to reconstruct the skull base. That is why it still needs surgery. So in spite of divergent procedure, the surgery is still indicated because it requires a skull base reconstruction. So our goal is reconstruct the skull base like we did in the first case.
Yeah.
Multi-layer exposure. See this. See this. Where it is coming out. Can you see? Hello?
Yes, yes. Yes, yes.
Where my cursor is. But now it is not very active. Frontals are good.
Yeah.
What about the frontal sinus? Is there a defect in frontal sinus also there?
No. Frontals are good.
Yeah, exactly that cut.
This one.
Yeah.
Yeah, we will see. But the frontal recess is good. And this was the site of leak, most likely. But you never know. Because he had so high intracranial pressure, if this is the site of leak, see, this is frontal sinus.
Yes.
Okay? Now look at the floor. As long as floor is there, it is frontal sinus. Now where is the floor? No floor?
Yeah.
See, until now is the floor.
Yes, yes.
And now, what is happening? The ethmoidal cavity coming in, the middle turbinate attachment coming in. See that?
Yes.
And if it is a defect, this is frontal recess. Can you see?
The supraorbital.
Yeah, you can say, because this is behind the frontal sinus. This is anteriorly frontal. As you go behind, this is a not very pneumatized, but supraorbital recess, part of the frontal recess. And if it is, we will demucosalize here completely and close it. That will be a simplest one solution to it.
Because even the MRI, I could see some CSF there. Can you just compare the MRI also?
This MRI was done before the, shunting.
Oh, okay.
This was 3D flare. So let's see. We will explore the anterior ethmoidal and the skull base and the frontal recess. See, this could be from here as well. See this?
Yes, yes, yes.
Yeah.
Coming like this. What you are saying. See that? Frontal recess. See where this bright signal coming from. Hello?
Yes, sir.
Yeah, yeah. Yes.
And now let me put up the flare together. It will give more information. Now. Yes, it could be this one. Here the CSF is bright and it is dark here. Hello?
Yes, sir.
Yeah.
So let's see. Last 3 days, this patient has no leak. And obviously, we'll find some defect if it is there, and we have to reconstruct it to prevent meningitis. That is the only goal. So the initial exposure part has been started by Dr. Shavendra here. I'll be joining him in a couple of minutes. So we'll be back in next 5 minutes. Meantime, you can collect question, Udbhav.
Yes, sir. Yes, sir.
From there.
Sir, if in the previous case there is a recurrence, then how will you manage? Dr. Mohammed Afsal wants to know.
See, it's a slow growing tumor. If recurrence happens to occur, we will evaluate exactly where it is going. And again, the answer is the void surgical resection.
Yes.
Adenocarcinoma, surgery. The primary treatment is surgery.
And so many people,
suppose it is other malignancy like neuroendocrine carcinoma, undifferentiated carcinoma, sinonasal undifferentiated carcinoma, rhabdomyosarcoma, the first line treatment is chemo, neoadjuvant chemo followed by either surgery or chemoradiation therapy.
Yes.
Here, in adenocarcinoma, undoubtedly surgery is the answer.
Yes, sir. And sir, if it happens to be squamous cell carcinoma, then what is the treatment plan? Surgery, then
Squamous is
radiotherapy?
aggressive. Squamous is
Okay.
aggressive. Squamous, had this been squamous, I would have resected the entire skull base with wide margins.
Okay.
Would
And sir,
never
with
take a chance.
and sir, with radiotherapy post-op?
Yes, 100%. Involvement of the skull base is the advanced malignancy. And
Okay.
you have to do every possible adjuvant therapy in those situations.
And so many people miss that point of CK7. Can you elaborate once again the importance of CK7 in adenocarcinoma? That marker.
In sinonasal intestinal type adenocarcinomas, CK7 positivity rules out the primary colonic carcinoma and sinonasal metastasis.
Yes.
So that is something you can't ignore.
Yes, sir.
Then the treatment you have to, see the entire skull base, entire abdomen to rule out the tumor, primary tumor in the colon.
Yes, sir.
क्या हुआ? चालू नहीं किया? बाकी हो गया? 5 मिनट का.
Sir, any role of frozen section in these cases, adenosquamous cell carcinoma?
Pardon, in adenocarcinoma?
Yes, sir. Frozen section of surrounding
it
tissue.
was not required.
Okay.
It was straightforward.
Yes.
It was not required. So we didn't go in for.
We have covered most of the questions. Mostly they are thanking messages and spellbound. People have enjoyed this Dashera weekend a lot.
Oh, thank you. Actually, in adenocarcinoma, when you have a lot of mucosal cyst at the expanding front, it is favorable. Like you saw, we removed the cyst with a complete wall. That is the answer. And
Yes,
what
sir.
skull base was thinned out was because of the pressure erosion, not because of infiltration.
Yes, sir.
Boss? So another 5 minutes to go. We can discuss meantime any question or anything.
Can this miss using the cobbleter on normal mucosa? Does any histopathological change or any change to occur?
No. Why would it's like cautery? What does coagulator do is coagulation.
Dr. Adwan he was asking this question.
So it devitalizes the mucosa. Those cells are no more functioning.
So Dr. Sridhar from Visakhapatnam wants to know any role of, if there is frontal sinus outlet is narrow, is there any role of stenting?
Stenting is a timing procedure, like in the previous case, first case we did.
Yes.
To prevent the, stenosis by means of materials we are using to reconstruct the skull base. So that is a timing. We have not done anything inside the frontal sinus. There's no pathology inside.
Yes.
This is to prevent the secondary blockage of the frontal sinus. Now, in other primary chronic rhinosinusitis conditions, recurrent frontal sinusitis, some people use stenting, but that is not a It has no place now with the advancement in the draft procedures.
Yes, yes.
Don't need all these. Nothing is required. A proper draft procedure is the answer in majority of the situations rather than stenting and all.
There was a previous out of the contest question. Dr. Nageshwar wants to know what is centripetal dissection and what is centrifugal dissection.
So what we did was a centripetal resection.
Okay.
Right from the peripheral luminal component to the central invasive component. This is called centripetal.
Yes.
This is exactly what we did in the first case, olfactory neuroblastoma.
Yes.
In such endoscopic techniques, this is piecemeal resection, centripetal resection, but yet radical at the site of resection. What all you need to do is luminal debulking from peripheral to the area centrally of invasion.
Yes, sir. And sir, Dr. Nadia wants to know in the CSF leak case, if by chance the leak happens after the Harad flap, then what other options do we have in those cases?
After the vascularized flap, the chances are negligible unless there is high pressure. So in those situations, see, there are certain indications for lumbar drainage or diversion. Not all cases. One is a persistent elevated intracranial pressure.
Yes.
Second is a revision situation with no flap available. Third is a post-radiotherapy situation. Any situation when there is no vascularized flap available, those are the situations where chances of leak are more, chances of failure are more, and in those situations, you have to use some sort of diversion procedure to minimize the intracranial pressure for your seal to take place.
Yes, sir.
Not in all cases. I take this opportunity once again to invite you to 21st and 22nd November for the biggest otology event of the year, the ISOCON webinar. That is a live surgical demonstration webinar from Jain ENT Hospital, Jaipur, with renowned faculty members coming in, wherein the range of otological procedures, right from the external ear to the variety of tympanoid sclerosis, ossiculoplasties, TPs, cholesteatomas, tumors, facial nerves, and many lateral skull-based procedures will be shown. 9 to 6, 21st and 2nd November. And you can log in at the same login what you have done today, expertsmeet.in.
Okay. Wonderful, sir.
Okay. So now we are starting, I mean, I am joining in. The basic exposure was, I told you, been done.
Yes, sir. Satish sir. Hello.
Yes.
Sir, Dr. Yogesh from Jaipur is saying that once he has in the CSF leak repair, he has observed that while putting fat in one of his cases, he got a mass effect over the brain. Have you encountered such thing in your practice? Any pressure effect of the fat over the brain?
by means of using these materials to seal the leak?
Yes, sir. Yes, sir. Any pressure necrosis of the brain or anything like that?
Not really. Never.
Yeah. We are getting the endoscopic picture, sir.
Very active leak.
हो गया? Hello?
Yes, yes.
Yes, sir.
Yeah. Now we are all set.
Very active leak is there. Very active.
Yeah, it looks, the pressure still looks high. It's not a simple seepage of CSF. The pulsations are, see that? Hello? Hello? Hello?
Yes,
Sir,
yes.
yes, sir.
We are with you. We are
Yes.
with you.
Yeah,
We are with you.
basic exposure part was being done by Dr. Shevendra. And now I will take you through the various areas. 71st. I will take you through 70 degree. अरे लाइट बंद कराओ. See, that is frontal sinus.
Yes, sir.
पतला देना है section. The frontal sinus is good. That was the area of the frontal supraorbital recess, which we are suspecting. See that? That looks okay. Can you see that? Hello?
Yes, sir. Yes, sir. We can see. Yeah.
That looks okay?
Yes, yes, yes.
Yes, sir. Yes.
This is the same area what our MRI was showing. See this?
Ah, yeah. Yes, yes. That's a CSF leak.
Yeah. Now what I will do, I will make the surrounding area raw. Now we'll give him a perfect seal. You have seen earlier in 2 cases. Following the
Yeah.
same principles. Scissors.
Yes. Yes, sir.
First, I will sacrifice this turbinate to get the good surrounding area. See, this is the key to get a good, flat, raw surrounding area to take your graft. That is most important. No compromise in that. The pressure is surprising.
Is the shunt open, sir?
Yeah, the shunt, it looks functional. I didn't know.
But this much of leak with the functional shunt, very unusual.
Yeah, Pankaj was बोला ना. How do they get to know about the functioning of the shunt? Boss, how do you get to know whether shunt is functional or not? Can this be, what will you see radiologically? What will it show? Hydrocephalus? No, ventricle size, no? No. Left. So, according to the neurosurgeon, what you asked, first they confirm if any doubt with the CT scan, if there is any ventricular dilatation happening. The bone is overall thin. See that? And then, okay, so first is to do a CT scan, and if there is any ventricular dilatation, then you can suspect. Second is by compressing the shunt chamber, if the pressure changes. And third is by doing a lumbar puncture to see the pressure, opening pressure.
Sir, all this may not work with the CSF leak, sir. With this much CSF leak, nothing of this could happen.
Yeah, this is amazing. Huh? I never expected such a high pulsations. See now what I am trying to achieve is the surrounding 1 centimeter raw area. Now give me calculator and 70 degree. See now, like you saw in the previous case, calculator, I will ensure ये तो आप देखो दुर्लभ जी के नोट्स है देखो नोट्स टू नीचे वाला नहीं लगा Hello. Hello.
Yes, sir.
I can see two sides. See, this is one. another is here. Very, very, tiny openings. No, would not cobbler. Oh. Demucosalizing the surrounding centimeter. बहुत में निकला है। हाँ ये सीटी हुआ ना देखो वो ना वो उसमें लैपटॉप में I am making the surroundings raw. That is the ethmoidal artery anteriorly 1 centimeter all around. I hope you can see the area of leakage.
Yes, sir.
You can see the hole in the dura.
Yeah.
0 degree. This much of the leak. And I think I should rotate a flap also along with that. Now the picture is very clear. The surrounding is prepared. Okay. Head ready? Head ready? Head is ready. Let me not take a chance in this patient.
Sir, I strongly believe that this is a non-functional shunting, sir.
Could be.
Maybe a lumbar manometer after CSF leak repair is good option.
This much of the pressure is not expected.
So Dr. Mohammed Gadwan wants to know, can we use the mucosa of the resected middle turbinate for the reconstruction?
Yes, that can be used as a free graft. A lot of people use the middle turbinate as a flap as well.
Yes, sir.
Middle turbinate as a flap. But that is not a very robust, reliable, and easy flap. Middle turbinate flap is never all that easy. See, there was a small here, so I have widened it to see. Oh, so now I have 2 areas to seal. Can you see?
Yes, sir, very clear.
And here, to stay on the safer side, I will rotate a small flap. It will not require a big flap. You can see.
So what are the maximum number of leads you have operated in a single sitting, like in one case?
Maximum number of leaks?
Yes, sir.
I have seen in one patient the 6 defects on the same side of the skull in a high pressure situation. Nice.
Okay.
See here, I am not going even to the floor because of this spur.
Yes, sir. Yes.
I don't need a very big flap as well. See, such a simple made flap. Hello?
Yes, sir. Yes.
I will get his stent checked.
मेरे को एक बार छत पे
See, it's a local, it is not a classical Haddad flap. You can see?
Yes, sir.
According to the need, I raise this minimal tissue. या नहीं काट दूसरी दो कैसे कैसे डालते हैं ये कैसे कैसे डालते हैं इनको नहीं पता क्या आपके पास ही आएगा
Sir, Dr. Nageshwar Rao wants to know, is Paul Casanova flap useful here?
Pardon?
Sir, Paul Casanova flap is useful here in this case.
You can think of, because this doesn't require a big flap. Yes, can be used, but once you have an option, section of a septal flap, the first choice, the most robust is the septal one. You know. Once you have a septal flap available, why to think other one?
Yes, sir.
See, this has been elevated till here. Okay. Let's see where it reaches. Always check the flap once you raise. See, it will cover both.
Yes, sir. Yes, both.
Okay. Now, my final goal is funny. Give me a mirror cell to dry up everything. Cobbletter. Now, mirror cell. See, now the things are clear.
Yes, sir. Yes.
Our material is ready. I had to plug at two places a snugly fitting, seal with the fat and the Surgicel. And that should seal the CSF completely.
Sir, if there are two small defects nearby, can we make it a single defect and then repair, or we should repair them individually?
No, we can repair individually. Why two? There is a long distance between these two.
Yes.
So now change to 70 degree. The favorite one.
Yes.
Code. What an interesting situation.
Yes, sir. We can see the pulsations clearly. Very pulsating.
No patient wants revision.
Yes, sir.
If your any additional procedure which gives you better result with any hardly
Yes.
morbidity, one should not think twice in this era. Cobbletter.
Sir, Dr. Nageshwar wants to know what is a genus flap. Genus. Genus flap. I don't know.
Genus is a bilateral Haddad flap, you can say.
Okay. Okay.
When you need to do reconstruction of a bigger defect, needing bilateral Haddad is genus.
Okay.
Haddad
Okay,
has
sir.
many modifications, Many modifications Haddad has seen. More than 15 types of flaps have been developed by combining lateral wall, floor, opposite side, opposite resurfacing the same side. So many combinations and, See now, hemostasis achieved. Now it is clear?
Yes.
This is
Yes, sir.
important.
Very
before you
clear.
seal.
Very clear.
This is important before you seal to achieve hemostasis. Chota dena fat. See what I'm doing. It's too big. You have to plug in such a way that it snugly fits and becomes self-holding.
So what is this instrument called which you use to plug the fat?
That is a hockey stick periosteum elevator, the fine one.
Okay.
This today's man of the match instrument. It is working
Yes, sir.
Very useful.
Yes.
See, it is snugly fitting.
Beautiful, sir. Yes.
Record that. Chota. Cut it. Give one more. Go there. Satish Jain. Satish Jain is a very useful thing.
Sir, love your concept of watertight sealing. This sealing of the defect with the Surgery cell, wonderful idea, sir.
See, it should become self-holding.
Yes.
Half in, half out. See that?
Yes, sir. Sir, can you elaborate on bath plug technique?
Bath plug can be done in little bigger defects, through and through bigger defects. Through and through means the last defect we did was a centimeter one, good for bath plug, but it was not through and through the Durance arachnoid. For through and through defects, what you can use, take a good a larger piece of fat and pass a suture through it, through and through the entire length. And then invert it proximo-distally. The suture should go distally inside the intracranial space. What a fat. Inside the intracranial space. See now it is sealed.
Yes, sir. Yes.
Yes. Now I will just carpet this area with a thin layer of fat, and then put the flap is already elevated. नहीं कर रही ना काम, समझ नहीं आती है, सिजर्स नहीं कर रही काम यार, हटा उसको. Now we will compress करने को. I will show you something. So this bath plug is very good when you have a defect like a centimeter or so. You can pass a thread through it, pass the thread distally in the intracranial space, and then pull it with a larger piece of fat. It should not come out again. So it will allow once you try to pull the string, the thread, it will allow the fat to flatten out. This is additional carpeting.
Yes, sir. Yes.
आधा कर चपटा चपटा करना घास. See, no leak at all.
Yes, ultimate.
See now? This is just a bony, this is not a site of leakage. This is in the bone only. Law. अब वो दो. Glue. Since there was no bone on this entire area, and Duro was pulsating just to invite more scarring, this additional carpeting is done. Okay? And finally, this is the beauty. This gives you a sense of security, Once you use a vascularized tissue, means forget about the infection, forget about the integrity of the seal. See this?
Yes, sir. Beautiful.
See now? See all sinuses are open. See how high pressure leak it was? Completely sealed?
Yes, sir.
That's it. Now nothing can change. See that? All sinuses are open and it will heal so fast. This will give primary healing. That's the beauty. It doesn't take more than 5 minutes additionally, and it gives you amazing sense of security. No patient wants a revision surgery, particularly for the CSF leak. No surgeon wants. Revisions are always challenging and CSF leak is much more. With this kind of, repair, to do and forget. That's the only word I can say. Any doubts?
All the 4 cases are ultimate today. Ultimate.
Yes, sir. Wonderful.
See, this gives amazing even pressure. Even pressure. फिर वही रख दी. And now, in the same manner. So you have seen the 3 procedures for CSF today.
Yes, sir.
See, the frontal is wide open. The sphenoid is wide open. You don't need to do any stenting or anything. See that? Nothing is required to be done. And now, on this silastic, if I place this, once this swells up, It will exert pressure like anything. Nothing will move now. See that? See how efficiently this is now going to exert smooth pressure. Smooth pressure all the way. See this?
Yes, sir. Yes.
With the vascularized flap below, with the kind of seal, I have only one word, just do and forget about it. 0 degree. छोटा कर चौधरी छोटा कर थोड़ा थोड़ा सा see I just have to keep this in place like this, okay, compressed. I don't have to press it hard. We are not supposed to do that. We are not supposed to displace that, just to keep that in place. That's it. And now the povidone iodine. That's it. So now this is going to exert. This is splinting till skull base. Okay?
Wonderful.
Key is exposure. In CSF leak, the key is exposure.
Yes, sir.
And second is the flap. Some people may call it overdoing, but you know,
Even a single
consequences of failure are so, unacceptable.
Even a single failure, 100 cases will miss renal confidence. Better to overdo it, no problem.
Any questions?
No, sir. I think we have covered all the questions. So, what we need to do to prevent the sneezing post-op, like any post-op medications for those things?
Post-op? Post-op, you can give a broad spectrum antibiotic and Dimox, nothing else.
Dimox is more than enough.
Practically, if your repair is good, nothing is required to be done.
But a post-op protocol, you give rest for 4-5 days, absolute rest.
Yeah, those are general conservative measures.
Yes.
Keep the head up, give laxatives, and all that. Nothing specific. See, once the vascularized tissue is placed anywhere with good vascularity, maybe a free flap or pedicle flap, the vascularity should be there. It works amazing. Vascularized flap is an indirect guarantee for not giving infection to the area. As you have blood supply, you have antibiotic going, that gives you guarantee for a faster primary healing. You know, in few weeks time, this area heals like completely mucosalized, nothing was done before. So there is primary healing. The septum may heal, may take a couple of more weeks, but that doesn't make any difference. That's not so important. So we give them saline washes. That's it. And it mucosalizes.
Yes. I think questions been covered so far. All the questions been covered so far. And
yes, sir, all the questions.
Wonderful Dasera today. Ultimate cases.
Enjoy
These
all
are
Dashera evening.
all refined cases. Ultimate.
Happy Dashera, Satish sir, Rajiv sir.
Thank you. Thank you, Vinod. Thank you.
Happy this year, sir. Thank you. It was a wonderful session. We really enjoyed it.
Rajiv boss, Udbhav, Sandeep, Pankaj boss, Dr. Cherian, everyone.
Muka, Deepak boss.
Was very nice. Narayan and Ashish, everyone. Thank you so much. See you soon.
Thank you. We'll meet.
The next one is on 21st and 2nd of November.
November,
2 days,
yes.
full live surgery. Thank you.
And thank you, Sun Pharma.